Good morning, everyone, and a warm welcome to all of you to today's webinar. Yes, sir.
We can start the session.
Yeah.
Over to you, Dr. Priya.
Good morning, everyone, and a warm welcome to you all to today's webinar, Beyond the Scalpel, a comprehensive webinar on liver interventions. Before we begin, I'd like to take the opportunity to give a brief introduction to Eira, Endovascular and Interventional Radiology Academy, which is established with the aim of providing a platform to empower young doctors with knowledge on cutting-edge technology and collaborative learning. It reflects on the goals of academic excellence and commitment to make a lasting impact in this ever-advancing field. We are all aware that the liver is a vital organ responsible for various metabolic functions, and any disease affecting it causes significant morbidity and mortality across the world. Interventional radiology, be it diagnostic or therapeutic, has become an integral part in the management of the same. Our webinar today aims at providing a review of these intervention in liver diseases. Our esteemed speakers shall be discussing various modalities for diagnosis, role of interventions, and the latest advancement in today's session. Welcome to everyone for today's session. Over to Dr. Prajvit Rai, sir, before we begin.
I thank each and everyone for joining for our webinar sessions. It will be a very interesting sessions with a lot of young and enthusiastic doctors going to speak today. And I welcome all the senior consultants and all the faculties who are supporting us and attending the webinars, including Ram sir. Thank you for coming for the webinar, and I welcome all the speakers and all the participants for this webinar. And let's start the session with our first speaker, Dr. Shreya from Narayana Hospital, Kolkata. Over to you, Dr. Shreya.
Thank you, sir. So the topic of my today's presentation is how to take an arterial access. So moving on. First and the most important thing is how to prepare the patient and the clinic visit. So first of all, we need to take a focused history detailing prior arterial accesses or any open procedures that the patient had had in past. Then we need to ask about the medications that the patient has been taking previously, and also the allergies, drug allergies, particularly in respect with the anticoagulation. After that, we need to clinically examine the patient and also perform ultrasound screening to assess the access point. And if you're planning to take radial access, then we should perform an Allen's test to make sure that the collateral supply to hand is maintained. Next is assessment of patient's bleeding risk. For this, we have a has bled criteria, which includes history of hypertension, abnormal liver or renal function, stroke, bleeding, labile INRs, elderlies more than 65 years of age, or drug and alcohol abuse. I wouldn't go into a lot of details because of time constrictions. Then we need to assess whether the procedure that we are performing has a low bleeding risk or a high bleeding risk. In cases of low bleeding risk, INRs and platelet counts are not routinely recommended, and we need to transfuse platelets only if the counts are less than 20,000. But in case of high bleeding risk, the INR should be maintained for within less than 1.5 to 1.8, and we need to transfuse platelets if the counts are less than 50,000. Moving on to pre-procedural imaging, as we all know that this is the main and the most important step, and we need to either perform ultrasound or do a CT angio or an MR angio for the assessment of arterial disease proximal to the puncture site, or any arterial tortuosity, any aneurysms or stenosis. And also this helps us to plan whether on which side we are going to take the puncture, or whether we are going to take a femoral axis or a radial axis. On the day of the procedure, we need to confirm the identity of the patient, briefly explain the patient about the procedure risks and the benefits, and also the alternatives. Then we also need to assess whether the patient would be requiring any anesthetic input or regional blocks. Also, we need to mark the entry site with a marker. Moving on to access needles and techniques. So before taking an access, we need to make sure of certain points, and we need to make sure that we are always taking ultrasound guided punctures. We should not take blind punctures. So first, we need to image the vessel in the longitudinal view, and the whole of the vessel should be visualized, and it should be in the center of our image. And for very superficial axes like radial axis and pedal axis, we can use hockey stick probe. Then second thing, our needle should be at the edge of our probe, and it should be angled for about 30 to 45 degrees. And the full shaft of the needle should be visible while taking the axis, because we need to make sure that we are puncturing the anterior wall of the needle, of the artery, I'm sorry. And we need to make the puncture using Scheldinger technique. And also we should puncture the single wall of the artery and not both the walls of the artery. So while imaging the artery in the longitudinal plane, we need to advance our needle at an angle of about 30 to 45 degrees. Then after we've punctured the anterior wall, we need to push the needle further inside into the lumen. After that, and also we are using hollow needles. So we introduce a stiff wire through the needle into the arterial lumen, and then remove the needle over the wire and then again advance and introduce a sheath. And after that, we can secure the sheath and remove the sheath dilator and the needle and the wire. So for femoral axis, we usually start with a 18 gauge needle. We can also use micropunctures for antegrade axes. We prefer hollow needles. And we use 035 Teflon coated standard J-tip stainless steel core wire because it is atraumatic and it is easier to advance via tortuous vessels. The size and length of the choice of sheath depends on the type of the procedure, but we usually start with a 5 French sheath with 11 centimeter length. So this is the arterial puncture set. We start with either an 18 gauge standard needle with an 035 guide wire, or a 21 gauge needle with a micropuncture guide wire and a 2-piece dilator. And we have various sheets available in different lengths and also in different French sizes, and they are color coded accordingly. And also they have a side port. For pedal axes, we use shorter sheath lengths, and also the French size is also shorter. We also make sure that we are using minimal local anesthetics while taking pedal axes, otherwise it will put extrinsic compression and it will collapse the vessel. For brachial and radial axes, we use micropuncture systems. For these axes, we can also use dedicated pedal and radial axis sheets. And also we need to make sure that we're taking a puncture over a bony prominence so that we can compress it later. For radial axis, we use a radial axis cocktail to avoid the disadvantages like arterial spasm. So we inject 2000 international units of heparin, 200 micrograms of nitroglycerin, and 2 to 5 milligrams of verapamil. Also, we dilute it with 20 ml of blood and inject it over a period of 30 seconds to 1 minute to prevent discomfort to hand. We've already talked about the image guidance. So we have demonstrated that routine ultrasound guidance decreases the frequency of access site related complications in large patient series and should be the first approach for all cases. And also, ultrasound permits to delineate the arterial anatomy, the level of bifurcation, presence of arterial plaques, and also allows us to use a single pass puncture. For radial access, we can use both the arms, but most people prefer the right arm, and distal radial access is preferred over the carpal bones. For brachial and pedal accesses, puncture of the brachial artery should be performed in distal part above the antecubital fossa, where it is relatively superficial. And at this level, we can compress it over the humerus to achieve hemostasis after the procedure. And for pedal accesses, the foot should be in plantar flexion while accessing distal DPA and ATA. It should be inverted for distal peroneal artery, and it should be everted and dorsiflexed for distal PTA. Moving on to procedural steps. So patient positioning is very important. For axillary and high brachial accesses, the arm is abducted for 90 degrees with elbow flexed and hand placed under the back of the head. For pedal accesses, we used feet first supine approach. And the foot is stabilized, knee is slightly flexed, and hip is slightly externally rotated. Ultrasound machine should be placed in such a position so as not to cause significant neck torque operating arterial axis. And the working area should be clear of radiopaque external medical devices such as cardiac or vital monitoring devices and lines. Moving on to sterilization and patient draping. So we need to clean the procedure site and the surrounding area with antimicrobial agents. And after skin preparation, we drape the patient with sterile sheet and towels. After that, and we also need to make sure of hand disinfection, which is very important. Next step is local anesthetic. So we usually use lignocaine and apply it to the skin and the subcutaneous tissue, and we should form a nice bleb. Lignocaine is acidic and this causes pain during injection. So this could be prevented if we add sodium bicarbonate along with it. Moving on to care during procedure. So intraarterial heparin is administered at 60 to 80 units per kg of bolus, followed by 200 to 400 microgram intraarterial nitroglycerin. And also we need to measure the ACT every 30 minutes to 1 hour, and heparin is administered accordingly to keep the ACT between 2 to 2.5. We also administer nitroglycerin in about every 10 to 20 minutes to avoid spasm of the vessels. Moving on to hemostatic control. So the most common technique that we use is ultrasound guided manual compression. So to perform this, the artery should be visualized in the longitudinal view. We put occlusive compression for about 2 minutes, followed by a slightly reduced pressure for about 15 to 20 minutes, depending on the size of sheath and coagulation status of the patient. It should be always performed against a bony structure, and the patient requires prolonged bed rest for up to 6 hours after manual compression. For radial accesses, we have specialized pressure cuffs that can be used for non-occlusive hemostasis. We also have vascular closure devices. These help in faster hemostasis and faster ambulation, and they are categorized according to the mechanism of action into active approximators, which are suture-based, and an example is Perclose. And the second is passive approximators. So these are gelatin-based, and the example is Angioseal. For larger vascular accesses, we should prefer suture-based devices, and elastocompressive dressings are used following hemostasis. So this is an example of angioseal and how angioseal forms a plug, gelatin plug, along the inner aspect of the arteriotomy site and seals the arteriotomy site. Moving on to post-treatment care. In the immediate post-procedural period, we must instruct the patients for bed rest for about 4 to 6 hours if we've used manual compression, or for about 2 hours if we've used vascular closure devices. We need to monitor vitals. We need to inspect regularly the access site immediately after the closure, before bandaging, and before giving any other medication. We should also perform ultrasound screening in obese patients or in cases of antegrade punctures, or if we see any visible bruising or hematoma. Also, we should assess the distal runoff to before and after the procedure. Moving on to in-hospital management. So clinical inspection is very important, 4 to 6 hours after the procedure, when we remove the elastic compression dressing and advise the patient to mobilize if we do not see any visible bruising or hematoma. But if we see significant hematoma, then we need to assess it with ultrasound, and we need to rule out whether there is any pseudoaneurysm. And if we see any pseudoaneurysm, we need to treat it with ultrasound-guided manual compression, with or without thrombin injection. We can also advise CT angiography in cases when we suspect active bleeding. Later on, we need to call the patient back after 2 to 6 weeks to perform an ultrasound Doppler screening of the access site. So moving on to complications. So the common complications that we come across are access site related, and these are hematoma, retroperitoneal bleed, or pseudoaneurysms. These are more common if we do not give adequate compression, if the patient has deranged coagulation profile, or if our location of puncture is not proper. The other complications could be arterial dissection, thrombosis, arteriovenous fistula, arterial spasm, or distal embolization. So what are the key learning points? Are number one, we should always assess bleeding risk before puncture. Number two, we should assess the access site, and we should make sure that the access site is free of any arterial wall pathologies. Then our puncture technique should be accurate, and the puncture site should be very accurate. We should always take it on bony prominences, and we should always puncture the anterior wall of the vessel. And after the procedure, it's very important to ensure hemostasis and to prevent all the complications related to access site. Thank you.
Thank you
Thank you,
so much.
Shreya. That was a great session by you. You have explained it in detail, and thank you for that. Now we have Dr. Aditya Shetty, who will be speaking about patient optimization. Over to you, Dr. Aditya.
Sir, can you please share your PPT?
Or transfer it to this. Transfer it to this. Drop. Okay. Wait. Have you shared the PowerPoint? Yeah. One second. Have you shared the PowerPoint? Okay, I'll be sharing the screen on behalf of Aditya.
Good morning, everyone. First of all, I'd like to thank the organizers for giving me this opportunity. So I shall be talking on patient optimization for liver interventions. Okay, so the basic steps in any patient who comes for any intervention would be the initial step is patient referral. So initially we take relevant history and go through the diagnostic studies, which includes laboratory and imaging findings, and then see if we have the available expertise to perform the particular intervention. Then once the patient comes to us, we generally go through the history and perform a clinical interview, get informed consent, go through their existing medications, coagulation profile, and other laboratory investigations. Post that, with regards to patient optimization, patient generally has to be fasting for any procedure which requires sedation, especially. We also optimize their bleeding chances based on certain factors. Contrast-induced nephropathy prophylaxis and pre-procedure antibiotic prophylaxis. So, immediate pre-procedure check includes IV access, a safety checklist or timeout, and equipment check. So the clinical interview consists of two steps, that is the basic steps and evaluation specific to IR procedures. So basic steps includes history and directed physical examination, review of current medications and allergies, review of laboratory findings, and going through the concerned imaging findings, that is cross-sectional and ultrasound imaging. Evaluation specific to IR procedures includes examination of the proposed puncture site, bleeding risk assessment, risk of contrast-induced nephropathy, and requirement for sedation. So the one of the things which is concerned with the liver disease would be the child pug score, which includes laboratory findings and clinical findings. So the lab findings are total bilirubin, albumin, PT-INR, and ascites. This can be graded based on their findings into 1, 2, and 3 points. So the total number of points are accumulated, and the patient is classified into class A, which is well compensated disease, well compensated disease, class B where there is significant functional compromise, and class C where there is um, uh, uh, basically decompensated disease. So class A is where the total points comes to 5 to 6, class B is where it comes to 7 to 9, and class C is 10 to 15, and the 1 year survival period for class A is 100%, class B is 80%, and class C is 45%. The other score which can be calculated for liver disease is MELD sodium score, which also includes sodium levels and serum creatinine, and whether the patient is undergoing dialysis or not. So coming to informed consent, this is a process where the patient makes a decision whether treatment has to be given based on information given by the healthcare provider. This is a legal and ethical requirement, and the information provided should include diagnosis, prognosis, purpose, main stages of the procedure, significant risks and complications, and other alternative options, and the key people involved in the procedure. If it is an emergent procedure or if the patient is unconscious, then consent can be sought from the immediate family member. With regards to patient pre-existing medications, if the patient is on antihypertensive, antiarrhythmics, bronchodilators, anti-epileptics, or thyroid or rheumatologic medications, then those should be continued. If the patient is on insulin, then and the procedure is planned for the morning, the patient can continue the insulin dose. If the patient is posted for midday, then 1/2 dose should be reduced. If the patient is on oral hypoglycemics, then it should be withheld on the day of procedure in order to prevent hypoglycemia. With regards to coagulation profile, most liver interventions are classified into moderate to high risk of bleeding. So with regards to moderate risk, patient should have INR, and if the patient is receiving IV heparin, then APTT should be observed, and platelet counts too. If it is a high risk procedure other than the above mentioned factors, hematocrit also should be considered. If the patient is having a INR of more than 1.5, then it requires correction with vitamin K, generally a dose of 5 to 10 milligrams, slow IV, or fresh frozen plasma can also be administered. So if the INR is between 1.5 to 2, then 1 FFT generally is sufficient. If it is 2 to 3, 2 FFTs are generally required, and 3 to 4, generally we transfuse 3 FFTs, and more than 4 will require around 4 FFTs. If the APTT is more than 1.5 in patients receiving IV heparin, then it requires correction. And platelets less than 50,000 also requires transfusion. So 1 STP would generally increase the platelets by 30 to 60,000, and 1 RDP would generally increase it by 5 to 10,000. With regards to fasting, if generally the recommendations are as follows: for clear liquids, minimum fasting period is 2 hours. For breast milk, breast milk, it is 4 hours. Infant formula and non-human milk, it is 6 hours. Any light meal is also 6 hours. So if the patient is posted for any emergent procedure, then there is a risk of aspiration. So in order to prevent aspiration, then probably prokinetics like metoclopramide IV 10 milligrams, or and airway protection also might be required. That is basically intubation. With regards to antiplatelets, if the patient is on low dose aspirin, then any liver intervention generally comes under moderate to high risk, so there is no need to withhold. If it is high dose, that is 325 milligrams, then there is a requirement for withholding for 5 days. If the patient is on clopidogrel, then there is a need for withholding for 5 days. If the patient is on silastazole, if it is moderate risk, there is no need to withhold. If it is high risk, then there is a requirement for withholding for 24 hours. If the patient is receiving tirofiban, then for moderate and high risk, the interval for withholding is 4 hours, and abciximab for both moderate and high risk, it is 24 hours. With respect to anticoagulants, if the patient is on warfarin, then the interval between last dose and procedure is generally 5 days, or if the INR has to be less than 1.5. This can be corrected with the use of FFP and vitamin K2 if it is an emergency. With the heparin, the interval for withholding is 4 hours for both moderate and high risk. For low molecular weight heparin, that is enoxaparin, then the interval is 12 hours. For oral anticoagulants, dabigatran, rivaroxaban, for dabigatran, it is it is 48 hours for moderate risk. For high risk, it is 72 hours of withholding. For rivaroxaban and apixaban, for moderate risk, it is 48 hours of withholding with resumption after 48 hours. With fondaparinux, it is again withholding for 36 hours and resumption after 6 hours in moderate risk cases. And in high risk cases, it is 48 hours of withholding and resumption after 6 hours. These are the most commonly used anticoagulants in general practice. With regards to contrast-induced nephropathy, it is defined as relative increase in serum creatinine by 25 to 50% above baseline within 72 hours. If the patient's eGFR is more than 30, then the risk of developing CIN is low. So, and if the patient is receiving IV contrast administration, or if it is a second pass intraarterial administration, then the risk of developing CIN is low. So these people don't require any form of prophylactic measures. If the eGFR is less than 30, and if the patient is receiving intraarterial administration of contrast, and if the eGFR is less than 45, then prophylactic measures are indicated. These the most commonly used prophylactic measures are IV fluids and administration of sodium bicarbonate. Other measures which can be given are isoosmolar contrast agents like Visipac, although there is no evidence to show that it is better than low osmolar agents. And also N-acetylcysteine can also be administered. eGFR should be calculated within 7 days in patients who are having AKI or in patients with CKD and sudden deterioration of kidney function. In stable CKD cases and other patients, eGFR measurements of up to 3 months can be considered. With regards to patients receiving metformin, they can be categorized into category 1 and category 2. So category 1 is where the eGFR is more than 45 ml. And in patients with CKD with eGFR of more than 30, and patients who are receiving IV contrast administration or second pass metabolism of intraarterial injection. In these patients, there is no need to withhold metformin, and post-procedure renal function is also not required. In patients with CKD and eGFR of 30 to 45 and first pass metabolism of intraarterial contrast administration, or patients with CKD and less eGFR of less than 30, these patients require metformin to be withheld for 48 hours prior to the procedure, and renal function has to be re-evaluated post procedure. With regards to antibiotic prophylaxis, the patients who are at risk are patients with biliary dilatation, biliary prosthesis, bilioenteric anastomosis, and presence of a tip shunt. So in these patients, the general antibiotics which are given are piperacillin tazobactam, or a combination of third generation cephalosporins with sulbactam. In complex cases, then involvement of a microbiologist also must be made in order to decide which antibiotic is suitable for that patient. With regards to uh, there is also a need for a safety checklist to be followed in order to prevent adverse events in patients. So one of the safety checklists is provided by CERSI, which is comprehensive and well made. So this includes patient details and what procedure is being done, and it includes a list of things which has to be seen with regards to procedure planning, sign in and sign out notes too, with name and signature for each column. So this is a well-made comprehensive list which can be followed in every department to prevent adverse events. Thank you.
Thank you, Aditya. That was a comprehensive session on patient preparation for any interventional procedure. Now we have Dr. Ritesh, who is going to talk about hepatic anatomy, going to hepatic proper of interventions. So over to you, Dr. Ritesh.
Hi, good morning, everyone. Can you see my screen?
No, sir, it's not visible.
Okay, it's just. Dr. Pajut, can you please share my screen? I'm issue with my presentation.
I'll share it, sir, from my end.
Hi, good morning. Today I'll be talking about segmental anatomy of liver. Before we do any procedure, it's very important to localize the lesion where it is. It's very important to know the anatomy of the liver. So segmentation of liver was described by Cournard, a French doctor, and is based on the identification of the three hepatic veins and the plane passing by the portal vein bifurcation. It is the most widely used classification as it is most suited for accurate localization and monitoring of intraparenchymal lesions. Therefore, the knowledge of anatomy of the portal vein venous system is essential, as is knowledge of the variants resulting from various changes occurring during the embryological development. So anatomy of hepatic veins. This is the most common presentation of hepatic vein, where we can see the right hepatic vein arising separately from the IVC, and the middle hepatic vein and the left hepatic vein having a common trunk. This is the most common presentation of hepatic veins. Next slide. The various variants are, one of the most commonly occurring variants are accessory right inferior, presence of accessory right inferior hepatic vein, which drains the right posterior inferior segment in the retrohepatic IVC. Two accessory right inferior hepatic veins, accessory vein draining the caudal lobe, absence of common trunk between the MHV and the LHV, absence of right hepatic vein and splitting of left hepatic vein and middle hepatic vein, and segment 8 vein draining in the middle hepatic vein. Next slide. So here on the left side, we can see the presence of two accessory inferior hepatic veins. And on the right side, we can see an accessory right inferior hepatic vein that is draining the posterior inferior segment of the liver directly into the IVC. Next slide. This is another variant where we can see the right hepatic vein, the middle hepatic vein, and the left hepatic vein arising directly from the IVC. Next slide. The anatomy of portal vein system and the variants. The portal vein is formed by the union of superior mesenteric vein and splenomesenteric trunk, which is formed by splenic vein and the inferior mesenteric vein. The intrahepatic portal variations are noted in about 20% of the population. The portal vein variants have been classified by Cheng as follows. Next slide. This is a diagrammatical graphical representation of various types of variations that are described by Cheng. Next slide. So here we can see type 1. This is the bifurcation of the portal vein, where we can clearly see the portal vein dividing into left and right portal branches. This is the most common presentation, which is seen in almost 85% of the patients. Next one. This is type 2. This is also called trifurcation of the portal vein, where we can see the right posterior sectoral portal vein and right anterior sectoral portal vein and the left portal vein branch arising directly from the main portal vein trunk. This is found in about 12% of the patients. Next slide. This is type 3, or it's also called type Z. Here we can see that the right posterior segment sectoral portal vein is arising directly from the main portal vein, and the right anterior sectoral portal vein and the left portal vein having a common origin. Next. Type 4, or it's also called the quadrification. Type 4, in which we can see that the right anterior sectoral portal vein is arising from the left portal vein branch. Next. The definition of various terms of liver segmentation is also very important. So there are two lobes, right and left lobes, which are separated by the umbilical scissura. The liver, the right and left livers are separated by the plane of middle hepatic vein and the plane of the gallbladder, which is also known as Cantley's line. There are various sectors, the parts of the hemiliver vertically separated by the plane of the right, middle, and the left hepatic vein, and various segments which are independent functional units receiving an artery, portal vein, and are drained by a hepatic vein horizontally separated by the plane passing by the portal vein bifurcation. Now let's come to the segmental approach, systematic approach to the liver segmentation. Next slide. Step 1 is the identification of the plane which is passing by the portal bifurcation. And just above the plane, we can see the 3 hepatic veins. So, and just below that plane, we can see the gallbladder. Next. Now we should divide the liver into right and left liver. So as we can see, the plane above the portal vein bifurcation, we can see the middle hepatic vein. So if we draw a line, imaginary line passing through the middle hepatic vein, that will divide the liver into the left and right liver. And the plane below the portal bifurcation, we can see a line passing through the gallbladder anteriorly and the IVC posteriorly, which is also termed as Cantley's line, which also divides the liver into the left and right lobes. Next slide. Now we should delineate the segment 1. We can see the plane passing the portal vein bifurcation, and the segment 1 is delineated very nicely with the green color. If we go above this plane of portal bifurcation, we can see the quadratal lobe just medial to the IVC. Next slide. Now the next step is to identify the right hepatic vein. The right hepatic vein divides the right lobe of liver into anterior and posterior sectors. Once we divide the liver into anterior and posterior segments, we can also divide the liver into the superior and inferior segments by, again, portal vein bifurcation. The segments that are present above the portal vein bifurcation are superior segments, and the segments that are present below the portal vein bifurcation, that is 6, 5, and 6, are the inferior segments. Next slide. Delineation of segment 4. So we can see the umbilical fissure on the left side. So a line pass, just if you go above the plane, the line passing through the umbilical fissure and the middle hepatic vein will will demonstrate segment 4A. And just below the portal vein bifurcation, the plane passing through the umbilical fissure and the Cantley's line will show the segment 4B. Now let's divide the left lobe into the segment of 2 and 3. Again, we can see the plane passing by the portal vein bifurcation. If we go one plane above, we can see the left hepatic vein will divide, draining the left segment 2. And inferiorly, if we see right medial to the segment 4B will be the segment 3. Next slide. Thank you.
Thank you, Ritesh. That was very good segmental anatomy of the liver. Up next, we have Dr. Priyanka, who is going to talk on hepatic Doppler. Over to you, Dr. Priyanka.
Am I audible?
Yes, ma'am. Yeah, you're audible.
Yeah. Good morning. I'm Dr. Priyanka, Fellow Interventional Radiology. I'm talking on hepatic Doppler. Normal portal vein is of less than 13 mm in caliber with antegrade hepatopetal flow at 16 to 40 centimeter per second with mild phasicity. It might have low phasicity or high phasicity, but the pulsatility index will be more than 0.5. Flow increases postprandially and when supine. There will be laminar flow at mid-portal vein and helical flow at porta hepatis. Do not confuse this for reversed flow. This helical flow will be accentuated in portal hypertension, post-TIPS, post-liver transplant, and in portal vein stenosis. Normal portal hypertension, the vascular findings include enlarged portal vein of more than 13 mm. There is loss of respiratory phasicity. Here in the waveform, the trough corresponds to atrial systole and peak corresponds to atrial filling. The pulsatility index, as the pulsatility increases, the pulsatility index will decrease. In portal hypertension, it might have slow flow less than 16 centimeter per second, or it might have absent flow because of stagnation or occlusion, or it might show a to and fro flow. There might be hepatofugal flow, thrombosed portal vein, or multiple collaterals will be seen. Most commonly seen on ultrasound are coronary veins, that is left gastric veins. Here we see retrograde flow in the left gastric vein. The short gastric veins are seen below the left lobe of liver. The recanalized umbilical vein can be identified on ultrasound. Here it is showing retrograde flow. Coming to hepatic artery, it shows hypertrophy with tortuous corkscrew appearance. There is increase in pulsatility and resistivity. This is parallel channel sign. Here we see two hypoechoic structures. Both are showing color. We have to rule out IHBRD when this is present. There will be increased resistivity index in splenic artery and renal artery. There is loss of respiratory variation in hepatic vein, superior mesenteric vein, and splenic vein with increased splenic vein caliber. In portal vein thrombosis, we have to always rule out very low portal flow. That is also known as portal vein pseudoclot. Here you have to reduce the velocity range and reduce the angle. Also, you can compress the lower abdomen to increase the portal flow. Versus in acute thrombus, you see mostly hypoechoic. It is mostly hypoechoic with dilated portal vein, and there is no Doppler signal. In chronic portal vein thrombus, you see cavernous transformation with multiple collateral vessels at portal vein bed. Versus a bland thrombus, a tumor thrombus might show an adjacent mass. There will be color signals within. Here it is showing arterialization of portal waveform because of high pulsatility. Reversed pulsatile waveform is seen in portal vein in congestive cardiac failure or tricuspid regurgitation because of transmission across the hepatic vein. It might also be seen in hereditary hemorrhagic telangiectasia because of arteriovenous fistula, and in cirrhosis because of arterioportal shunting. Coming to stenosis, whether portal vein or hepatic artery stenosis, before the level of stenosis, you see decreased velocities. After the level of stenosis, you see decreased velocities. At the level of stenosis, you see increased velocities. Velocity more than 3:1 at the stenotic site is called significant. Resistivity index will be high before stenosis and will be low after stenosis. There will be turbulent post-stenotic flow with post-stenotic dilatation. At the post-stenotic level, there will be Power status waveform. This is subjective evidence of stenosis. Objective evidence of stenosis include acceleration of less than 5 meter per second, time to peak more than 70 meter per second, and low resistivity index. When there is a portal vein aneurysm, it might be asymptomatic or it might be large to thrombose, rupture, or cause mass effect. You will see a bidirectional flow, or also called as the yin-yang sign or Korean flag sign. In Abernethy malformation, type 1 is complete absence of intrahepatic portal vein. In type 2, there is patent hypoplastic intrahepatic portal vein. Type 1A and 1B is differentiated based on presence of splenic vein or SMV confluence. Here we see portal vein draining to IVC. Congenital intrahepatic portosystemic shunt. This is also known as the Park classification. In type A, there is single tubular connection between right portal vein and IVC. In type B, there is multiple peripheral shunt within one segment. In type C, there is portosystemic shunt through portal vein aneurysm. In type D, there is multiple peripheral shunt in 2 lobes. In type E, there is patent ductus venosus. Normal hepatic vein has thin imperceptible walls and is triphasic. It shows reversed retrograde 2 waveforms, that is A wave and V wave. A wave is atrial systole. The S and D waves are retrograde waves or antigrade waves. They show S corresponds to ventricular systole. The D corresponds to ventricular diastole. The S wave will be deeper than the D wave. The V wave might cross baseline or might not cross baseline. A wave will always cross the baseline and it will always be wider than the V wave. The increase in phasicity of hepatic vein gives pulsatile waveform. There will be tall A and V waves with dramatic fluctuation. These are seen in tricuspid incompetence and in right-sided heart failure, congestive heart failure. In tricuspid incompetence, there is decreased or reversed S wave. The S and D relationship is not maintained. If the tricuspid incompetence is very severe, there will be a retrograde flow in the S wave, giving ASV complex. In right-sided congestive heart failure, there is maintained relationship between the S and D wave. Loss of phasicity in hepatic vein and spectral broadening is seen in cirrhosis and in Budd-Chiari syndrome, and also can be because of improper technique. So we have to always make sure to examine hepatic vein in incomplete inspiratory breath hold. Farrant and Merry subjective scale of classifying the loss of phasicity in hepatic vein is as follows. It is mildly decreased when A wave crosses beyond the baseline. It is moderately decreased when A wave is halfway between the baseline and the peak downward wave. It is severely decreased when there is no variation in phasicity. Dampening index for hepatic vein is defined as minimal to maximal velocity of downward hepatic vein. The normally is of less than 0.6. In severe portal hypertension, it will be more than 0.6. Aphasic hepatic portal vein flow is seen in Budd-Chiari syndrome. It is usually chronic. It will show thick echogenic wall. Here we see middle hepatic vein and left hepatic vein showing echogenic content, and the distal middle hepatic vein is showing narrowing. This is hepatic vein star appearance because of hyperechoic depiction. There is decreased phasicity or attenuation of pulsatile waveform. There may be echogenic intraluminal filling defect and turbulence at this level of stenosis, or you might see a web. There is reverse flow in large hepatic vein upstream to obstacle. There will be interhepatic collateral vessels showing undulated course, Hawkistic appearance, or curvilinear appearance. These do not correspond to normal vessels. There will be caudate lobe hypertrophy with dilated veins. You have to always rule out cardiac failure. Also, there will be collaterals from hepatic vein to the caudate lobe veins. There will be tortuous collateral subcapsular veins draining to the IVC. There's bicolored hepatic vein draining to another hepatic vein. In 25% of patients with Budd-Chiari syndrome, they also have portal vein thrombosis. Here we can also see hypertrophic hepatic artery. In normal hepatic artery, there is sharp upstroke. This is a pulsatile waveform, which is antigrade throughout the cardiac cycle. It is a low resistance vessel with the resistivity index of 0.5 to 0.7. The high resistance is less specific for disease than is low resistance. it might there is increase in resistivity index in hepatic artery and cirrhosis and in transplant rejection. There is decreased resistance in transplant stenosis and in cirrhosis. The cirrhosis can have increased resistance because of compression, or it can have decreased resistance because of arteriolar microproliferation or arteriovenous shunting. The net resistivity index is not useful diagnostic cirrhosis or predicting its severity. In hereditary hemorrhagic telangiectasia, you can see a hepatomegaly, nodular liver. In hepatic artery, you see caliber of more than 7 mm. Intrahepatic arterial hypervascularization. These two are major criteria to diagnose hereditary hemorrhagic telangiectasia. If both of these are present, you can diagnose hereditary hemorrhagic telangiectasia. The minor criteria include flow in hepatic artery more than 110 centimeter per second, low RI with tortuous extrahepatic course, and high flow in portal vein more than 25 centimeter per second. In transjugular intrahepatic portosystemic shunt, at the level of cephalic end of the tips, this is seen in blue color, the waveform is below baseline, this is antegrade flow. At the caudal level of the tips, this is seen in red color, the waveform is above baseline, this is antegrade flow. At the level of right or left portal vein, the waveform is below baseline, this is hepatofugal flow, this is a functioning tips. In the main portal vein, the wave it is red in color, the waveform is above baseline, this is expected hepatopetal flow. The standard tips is to examine a sample at 3 parts of the shunt, any intervening hepatic vein segment, and in right, left, and main portal veins. There you will see a flow completely filling the stent with monophasic pulsatile waveform and high PS3 in hepatic artery. In tips malfunction, you will see an intrahepatic portal vein flow that was hepatofugal on prior examination has now changed to hepatopetal. There will be development or recurrence of collateral vessels such as recanalized umbilical vein. You might also see a new or recurrent worsening ascites. Here you see an occluded stent. Thank you.
Thank you, Dr. Priya. That was a very interesting talk on hepatic artery Doppler. Now we have Dr. Venkat from Max Hospital, who will be talking about the tips and some idea about HVPG. Over to you, Dr. Venkat.
Am I audible?
Yes, you're
audible.
Okay. So, very good morning to everyone. Okay. So, today I'm going to speak about portal hypertension and management, and I'm going to discuss few details about HVPG and TJL. So, generally, all the abdominal organs drain into the portal system by the superior mesenteric vein, inferior mesenteric vein, and the splenic vein, and through collateral vessels. And generally, the flow is towards the liver parenchyma, which usually describe it as capital flow. And once the blood flows into the liver parenchyma, it gets filtered across the sinusoids and enter into the systemic circulation, that is the IVC, to the hepatic veins. So, there is a hemodynamic concept in discussion of portal hypertension, where this is the normal microarteries in the liver parenchyma. So the blood flows from the sinusoidal lumen and it gets filtered across the fenestra within the sinusoidal endothelial cells and to the hepatic stellate cells, and it passes into the IVC to the hepatic veins, and this is the normal hepatopetal flow. And what happens in cirrhosis? There will be reversal of flow, that is the hepatofugal flow, where there will be some kind of obstruction at the level of liver, so that the flow, instead of going toward the systemic circulation directly into the IVC, it starts flowing backward. At this time, there will be enlargement of so whenever there is a backflow in the portal vein system, there will be enlargement of the normally collapsed collateral veins, which are usually in small caliber. And once there is portal hypertension, there will be enlargement of these veins and forms varices. And there will be stages of blood in the SMV, IMV, and these lead to hydrostatic edema and ultimately leading to ascites. So since we are dealing with the hemodynamic concept, we can assess portal hypertension based on the imaging findings as our previous speakers mentioned. However, how to measure it clinically? So how to assess the portal hypertension? So this is done by measuring the portal pressure, and there are various methods to measure the portal pressure. It can be either a direct methods or indirect. The direct method is by these are both direct methods are usually invasive and very dangerous, especially in cirrhotic patients because of risk of coagulopathy related bleeding. And these include clinic pulse pressure measurement and direct portal vein pressure measurement. And indirect pressure measurements are hepatic vein pressure gradient, that is the HPPG, and endoscopic variational pressure measurement. So what is hepatic venous pressure gradient? So in hepatic venous, in the name itself indicates it is a gradient between the hepatic veins, that is the systemic circulation, and the portal venous pressure. So how do we measure? Generally, we take the right jugular axis and enter into the right hepatic vein or left or any of the hepatic veins, and we advance our catheter into the hepatic vein and exchange it with a balloon catheter, uh, and once we inflate the balloon and do a contrast run, we can see there is a stasis of contrast in the distal hepatic vein, and this gives and we can measure pressure at this level, and this gives the indirect portal venous pressure because we are already wedged the balloon into the distalmost portion of the hepatic vein and taking the pressure. This is an indirect measure of the portal pressure. And once we take the wedge pressure, then we deflate the balloon and takes the pressure in the hepatic vein where the catheter is floating freely, and we call it as the pre-hepatic vein pressure. And once we, since generally the portal circulation pressure will be higher, we get a normal portal vein pressure will be around 5 to 10, and in portal hypertension it increases above 10. So if the pressure gradient between the wedged hepatic venous pressure and pre-hepatic venous pressure is greater than 5 millimeters, we consider it as portal hypertension. And if it is greater than 10 millimeters, we consider it as clinically significant portal hypertension. And these patients are at a high risk of encephalopathy. And if it is more than 12 millimeters of mercury, these patients are at high risk of variceal bleed. And hepatic venous pressure gradient is also useful in determining the cause of portal hypertension by its values. In sense, like in case of pre-hepatic and pre-sinusoidal liver pathologies associated with portal hypertension, usually the wedged hepatic venous pressure and pre-hepatic venous pressures will be normal and HPG will be normal. And in case of sinusoidal disease or post-sinusoidal disease, the wedged hepatic venous pressure will increase because obviously there will be increased portal flow, portal flow, and pre-hepatic venous pressure will be normal, and the HCPG will be increased. In case of heart failure, both wedged hepatic venous pressure and pre-hepatic venous pressure increases, and usually the values will be normal or near normal. And in Budd-Chiari syndrome, usually the hepatic vein cannot be cannulated and we cannot assess. So what is the basic pathophysiology here? Elevated portal pressure causes hepatofugal flow and variceal varices. And this can lead to bleeding, and with elevated portal pressure, there can be associated ascites and encephalopathy. So what are the radiological management of TIP? Radial management of it's portal hypertension. So reduction in the portal venous pressure, which can be either done by either tips, or if there is any portal vein narrowing and stenosis, then we can do a recanalization of the portal inflow, or if there is any hepatic venous outflow obstruction, we can recanalize the hepatic outflow. And if there is any arterioportal fistulas leading to portal hypertension, we can embolize the arterioportal fistula and partial splenic artery embolization to reduce the portal inflow. And for palliation of portal hypertension syndromes, symptoms, we can use percutaneous transhepatic variceal embolization and BRTO or image-guided paracentesis and percutaneous peritoneal venous stents. So, what is the main purpose of using tips to decompress the portal hypertension? How we do it? By creating a shunt between the high pressure portal system and the low pressure systemic circulation. And this reduces the likelihood of variceal ruptures and bleeding and also relieves the ascites. And it is considered safer than surgical and endoscopic alternatives. And what are the established indications? Acute variceal hemorrhage unresponsive to medical therapy, or recurrent variceal hemorrhage that is unresponsive to medical therapy, refractory ascites and refractory hepatic hydrothorax that is due to cirrhosis. And other less validated but promising indications include portal hypertensive gastropathy, hepatorenal syndrome, initial treatment for variceal hemorrhage or ascites, and bacterial lesions. What are the absolute contraindications? Acute permanent liver failure, active sepsis, and severe heart failure and severe pulmonary hypertension. And what are the relative indications? Any tumors or masses that can be in the tract, the shunt, or cavernous transformation of the portal vein, and severe or uncontrolled encephalopathy, and deranged coagulation profile with INR greater than 5 and thrombocytopenia that is platelet less than 20,000. So how do you evaluate the patient? You should assess the patient's morbidity post-tip. So for that we have two scales, that is the MELD score and the Child-Pugh score. And MELD score is a complex formula, and based on the MELD score, it can range from 0 to 40, and 0 to 12 indicates low risk, low mortality risk, and 13 to 17 is some risk, 18 to 25 is high risk, and greater than 25 is only just for compassionate risk. And Child-Pugh score, any Child-Pugh class 3 patients are poor candidates for tips. It doesn't give much help in those candidates. And the role of diagnostic imaging is always very, very much important to see the imaging before going for tips, because in generally these patients will be cirrhotics and their level will be shrunken, and the normal, it will not be the normal anatomy won't be seen generally, and one should always go with anatomical to have to look for anatomical relationship between hepatic and portal veins, look for any masses like I described, and bile duct obstruction, presence of varices and ascites. And always go with your CT scans or MRI, whichever is provided, and plan the tips even before going into the lab. And pre-procedure obtain informed consent and discuss the potential risks and benefits of the procedure. And patient's hemodynamic monitoring should be done continuously, especially if the patient is bleeding. And IV antibiotic prophylaxis, broad spectrum IV antibiotics should be given before the procedure. And procedure can be performed either under general anesthesia or conscious sedation. And patient should be draped in sterile fashion. And if you're using trans-abdominal ultrasound during the procedure, the abdomen also should be draped along with the neck. So what are the instruments that we use? A long vascular sheet, usually tension sheets will be used. And these are the ring kit, and to take it, I will discuss it shortly. And stent graft, that is the white stent graft. If you're not, if white stent graft is not available, then you can use two stents, covered and an uncovered stent. And this is the roof set, the rock which is set, where it consists of a proper turret that is used for puncture, and it can over which we put a 5 French blue color catheter and a stiffening cannula with a catheter over it and a dilator. And this is the vital stent graft, which consists of a covered portion and uncovered portion. Usually, the covered portion will be deployed towards the hepatic parenchymal side and the uncovered portion towards the portal side. So, procedure, first we need to take access and then navigation towards the treatment site, and then finally the puncture and stent deployment. So, right IJV access is usually used, and puncture should be done generally under ultrasound guidance. And once the puncture is done, always advance your wire across the right atrium into the IVC. And before going further, first take the right atrial pressure always take the pre-tips pressure of the right atrium. Then once you enter into the IVC, take an IVC gram and excuse me. Yeah. Always take an IVC gram. Then confirm the position of the hepatic veins and direct your catheter over the wire into the right hepatic vein. And usually the right hepatic vein traverses posteriorly, laterally, and inferiorly. And obtain a hepatic venogram, and just to visualize the where the hepatic vein is entering into the IVC. And if CO2 photography is available in your hospital, just go for a wedge CO2 photography. This will help us to delineate the entire portal system with the, and this can help in planning the portal function. So if you are standing at the head end of the patient, this is how an operator looks into the patient, and this is how it is seen. And your hepatic veins will tentatively be in this direction. The right hepatic vein will be laterally oriented and posteriorly oriented. Middle hepatic vein anterolateral and left anteromedial. And this is the portal vein. And if you are going to puncture the right hepatic right portal vein branch, from the right hepatic vein, you should your puncture should be directed anteriorly, and if you are going from the middle hepatic vein into the right portal vein branch, your puncture should be directed posteriorly, and so on. And once you confirm the position of the catheter in the right hepatic vein, then you introduce a long sheath into the hepatic vein ostium, and then a stiff angled metal cannula with a 21 gauge sheath needle should be introduced. And this arrow on the metal cannula is very important because uh, if the moment you rotate this angle, the inner curved end of the metal cannula rotates, and it helps in puncture of the. So the more you should rotate anti-clockwise if you want to turn the tip of the metal cannula anteriorly, which is usually the case. And once you advance your needle, puncture needle inside the lumen, in our institute, we use a transabdominal ultrasound guidance. However, you can go either by conventional method or based on bony landmarks, or you can use intravascular ultrasound to guide the puncture. And this is how once you puncture the portal vein, wait till blood. There is a reflex of blood into the catheter back, and then advance the wire. In this case, we after puncture, we are trying to advance the wire. Initially, it is going into the intraparenchymal branches. Then suddenly, it slips into the main portal vein. So once you advance the wire into the main portal vein, take a advance a catheter and take a portal venogram, and always remember that your external metallic uh, cannula, the angle should be maintained until the entire system gets stable. And get a pre-tips portal venogram, and as well as take a pre-tips portal pressure here. And then you can calculate the portal systemic gradient by subtracting right atrial pressure from the portal venous pressure. And once you are done that, advance a amplified stiff guide wire, and then balloon dilate the tract. This is how we balloon dilate the parenchymal tract. And after that, advance a measuring pigtail into the portal vein, and then take a simultaneous run from both the hepatic vein side as well as from the portal vein side, so that you can exactly know from the length of the stent graft that has to be deployed. And the distance between each marker is 1 centimeter. This gives us the approximate length, and always look for varices, purching varices, that is joining the portal and splenic veins. So after that, once you dilate the tract, advance your long sheath into the portal vein. Then in our institute, like I told, we use both covered stent and uncovered stent. So this is how we deploy the covered stent into the parenchymal tract, and we balloon dilated the tract. And after even after balloon dilatation of the tract, we saw there is still persisting varices. And this is how we deploy the uncovered stent within the covered stent. and then balloon dilate the stent. And even after that, we can still see varices, indicating that there is still a significant portal hypertension. It takes time for that to get relieved. So at this time, what can we do for the varices? We can either embolize with coils, plugs, or sclerosant material. So in this case, we saw this is the coronary vein on the left side of the image, and this is some short gastric veins that are enlarged. And then we coil embolize both the veins, and we perform the post-tips portal venogram, which showed free flow of contrast into the right atrium across the tip shunt. So this is the final picture. So what are our targets? The pressure gradients. And for varices, the pressure gradient should be at least less than 12 millimeters of mercury. And for ascites, if the indication of tips is ascites, the gradient should be less than 50% of what the initial gradient is before the pressure, or it should be at least less than 8 millimeters of mercury. If the gradient is high, we can try to dilate the tract. Post pressure, all the access catheters and vice should be removed, and just general compression is sufficient, and there is no need for any suturing or closure devices. And follow-up imaging post tips should be done at 3, 6, and 12 months to assess the tips patency. And if there is any stenosis, there might be requirement for balloon plasty. What complications can we expect after tips? Since we are shunting lots and lots of blood from the portal circulation to systemic circulation, there can be significant hemodynamic changes, especially if the patient is already a known cardiac patient. There will be significant hemodynamic changes, and minimal transient pulmonary edema is usually expected, and it usually gets relieved. And encephalopathy is seen in 10 to 25% of the patient and can be managed medically, unless if it is significant enough, then we need to reduce the tip shunt. What major complications can we expect? Hemophilia, hepatic arterial injury during puncture, gallbladder puncture, or malpositioning of the stent with the covered portion of stent in the portal vein, and hemoperitoneum because of inadvertent puncture of the liver parenchyma and capsular rupture. And since this takes a long time for a newer intervention, for fresh intervention radiologist, there can be associated a radiation burn and radiation injury both to the patient significantly and to the personnel themselves. And if there is hepatic encephalopathy, medical management will be with lactulose or rifaximin. And in case of what are the alternate versions of tips? It can be tips that is direct intra-hepatic portosystemic shunting, where if the hepatic veins are not accessible for accessible, as in case of Budd-Chiari syndrome, we can go for dips and IVUS guided tips and BRTO. BRTO will be discussed later. And a small note on transvenous liver biopsies. Transvenous liver biopsies, just whatever we saw in tips, how to access the right hepatic vein, it all goes similar way. But what are the indications for transvenous liver biopsies? It is uncorrectable coagulopathy and massive ascites, morbid obesity, and permanent liver failure, or presence of vascular hepatic tumor or pileosis hepatis. So how do you proceed? This is the TJLB set. We call it TJLB, transjugular liver biopsy, and it consists of a colloquinto needle with a 9-French sheath and a true cut biopsy. This is the true cut biopsy needle, and this is the colloquinto needle with the sheath. So then, similar to that, we enter into the right IJV, enter into the hepatic vein, and then confirm the position by doing a venogram, and then insert the true cut biopsy needle and take the biopsy. Thank you.
Thank you, Dr. Venkat. That was an extensive talk on TIPS, HVPG, and TJLB. So I think we are running late from our schedule. So we'll quickly go to our next topic on BRTO on Parto by Dr. Anurag Mahendrita. Over to you, Dr. Anurag.
The voice like
Hi, good morning, everyone. Am I audible?
Yes, you are audible.
Hi, thank you for inviting me here. And I am Dr. Anurag, and I'll be talking about BRTO and its variants. Please pardon my bad voice. I have sore throat. I'll try to cover the topic in the stipulated time. So let's jump right into the topic. I'll be covering the topic under the following headings. So the previous speaker has made my life easier by talking about portal hypertension and setting the ground for varices and portosystemic shunts. That's the anatomy. Is my pointer visible?
Yes, it's visible.
Thanks. So that's the portal circulation, and we all know that in the setting of chronic liver disease and portal hypertension, portosystemic shunts and varices are seen to open up and they require treatment. The portal circulation, as alluded to in the previous talk, cannot be accessed directly, and our access can either be antegrade through the trans-TIPS approach, which is complicated. It can be the dreaded transhepatic approach or the even more dreaded transsplenic approach, which are best avoided in the setting of CLD. And hence, whenever we have a shunt and an access through the systemic route, the transvenous systemic route or the retrograde route, that is always easier to access. So that's what it stands for, balloon-assisted retrograde transvenous obliteration of varices, where we go via the retrograde route, inflate a balloon into the shunt through the venous end, and then obliterate the varices using sclerosants. The term was coined by Kanagawa in 1990s, where they used ethanolamine oleate for the procedure. And shunt occlusion, as we talked about, can be done antegrade as well as retrograde, and both the treatment modalities have their own place in various settings, as we'll talk about. So spontaneous portosystemic shunts are known to open up in portal hypertension. These are the most common ones, and they can be a myriad of shunts which can open up, but the most common one being the gastrorenal shunt and the gastrocaval shunts, which are associated with gastric varices, and the splenorenal shunt, which is associated with hepatic encephalopathy most commonly. The splenogonadal shunt is also a common one, which is seen with hepatic encephalopathy, but the most common one is the splenorenal shunt, which we see is communication between the splenic vein and the renal vein, and hence is a portosystemic shunt, which leads to encephalopathy. So the indications of BRTO are broadly two. Gastric variceal bleeding, these could be impending, prior, or actively bleeding varices. And all this has been stated in the consensus statement of Bavino 7, which were published in 21, where they've talked about the various techniques of management of portal hypertension in various scenarios. And they talk about BRTO as an effective technique. And then hepatic encephalopathy. So as we discussed, large shunts in portosystemic, in portal hypertension have been associated with encephalopathy, and the Bavino 6 group, which talked about the management of hepatic encephalopathy in portal hypertension, have alluded to the use of shunt occlusion in this scenario. Hepatic encephalopathy is a clinical diagnosis. We use the West Haven classification, and anywhere grade 2 or more is significant. And we have seen that more than 70% cases of refractory HE have been associated with large shunts, and hence are amenable to shunt occlusion and treatment. The initial treatment is always medical, and only in cases of refractory HE do we resort to these interventions. The contraindications of this procedure would include severe uncorrected coagulopathy, as would be in the setting of acute liver failure. Splenic vein thrombosis, if we have time, we can talk about it, where we cannot do a straightforward BRTO, as also in portal vein thrombosis, where recanalization has to be combined with BRTO. Otherwise, we'll occlude the only outflow to the portal circulation that exists through the shunt. Uncontrolled esophageal variceal bleeding is also a relative contraindication, because in cases of esophageal varices, we have seen that once we occlude the gastric varices, the esophageal varices are shown to further progress and increase and lead to further torrential bleeds. And if it is a predominant esophageal varices, then we have to resort to antegrade approaches to management rather than the retrograde approach. So coming to gastric varices, we have the serine classification. The most common ones would be the isolated gastric varices, which we are dealing with, where we have the gastrorenal shunt associated with the varices, and also the afferents are mostly the short gastric and the posterior gastric veins from the splenic vein. And then we have the gastroesophageal varices type 2, where although esophageal varices are there, we have fundal varices as well. And here we'll find that these are also fed by posterior and short gastric veins predominantly. But in cases where the esophageal component or the coronary component of the afferent is large, we might have to do a combined procedure or combine it with an antegrade embolization as well. So these are the theories which justify the use of retrograde approaches in portal hypertension. The proximity theory talks about the fact that the short gastric and the posterior, so I can come back to this diagram. So the short gastric and the posterior gastric veins are to the left of midline, whereas the coronary vein is to the right. And if we create a TIPS, the coronary vein is amenable to decompression more than the distant located short gastric and posterior gastric veins, which are more amenable to left-sided treatment, and that is the BRTO. So, and hence, for left-sided portal hypertension or the low-pressure portal hypertension, we are subjecting the patients mostly to BRTO. And the throughput theory talks about the fact that if there is a spontaneous portosystemic shunt and we create a TIPS, then this shunt will definitely compete with the TIPS and can lead to early TIPS dysfunction, and hence occlusion of the shunt becomes imperative. The recruitment theory justifies the obliteration in BRTO, as in cases where we do antegrade embolization of the feeders, we see that even if the feeders are knocked off, the varices, if they are left in place, they might recruit other collaterals and hence lead to recurrence. And hence it is important to occlude the outflow and then inject sclerosant uphill, leading to obliteration and not just occlusion of these varices, and hence to ensure complete treatment. So this is just a diagrammatic representation of the same. These are the gastric varices fed by the splenic vein. Various afferent feeders can be there. And then we have the gastrorenal shunt, which is the outflow, which we access through the renal vein or the gonadal vein. And then we occlude this and treat these varices and obliterate these varices. Whereas for hepatic encephalopathy, we have a shunt between the splenic vein and the renal vein, and here the shunt occlusion is required for management of encephalopathy. So coming to pre-procedure evaluation, in today's era, we have to resort to a multidisciplinary approach. We must get a clinical opinion from gastroenterologist and endoscopic evaluation for the variceal status. So this is a recently published meta-analysis where they've talked about, they've compared various endoscopic and radiological interventions for management of gastric varices. Although BRTO is on top of the list, But the endoscopic coil and glue injection is also a decent technique to handle these, and especially in the emergency setting. And then the risk of rebleeding again was found to be lowest with BRTO, but also followed by the EUS guided techniques. And hence, endoscopic evaluation is a must, followed by lab evaluation, where we want to look at the liver function, the platelets, the INR, and the creatinine. We want to look at the MELD score. We want to look at the CTP, and only in cases of CTP A and early B should we be looking at these interventions. Otherwise, they can lead to worsening portal hypertension and decompensation. Imaging is again important. We need to document the patency of the portal veins, the presence of shunts and varices, and the anatomic considerations, which I'll allude to later. So now we come to the technique, talking about planning steps, hardware, as well as variants of this procedure. So this is the renal vein and the gastrorenal shunt leading up to varices. These are the gastric varices. So first of all, we have to look at the outflow classification, where we look at the outflow. Type A would be the gastrorenal shunt, and that's the gastric varix, and the gastrorenal shunt, isolated single dominant shunt. We go in, do a BRTO, nice and crisp, and this is a good result. But in cases where we have type B, where we have outflow through these collaterals, the inferior phrenic or the pericardiophrenic veins, we need to occlude them. We might occlude them if they are very small. We might occlude them using gel foam slurry. If they are large, we might use coil or glue to embolize these. Otherwise, these will form a low pressure outflow where we inject the sclerosant. These will act as outflow, and our procedure will not be successful. In type C, we can have two codominant shunts. This is the gastrorenal shunt and the gastrocaval shunt. And in such a scenario, we might want to do two balloons occluded or plugs in separately in these two shunts. So they have to be both dealt with individually. And type D, where there is no dominant gastrorenal shunt or gastrocaval shunt, where we have to resort to the antegrade approaches via the portal circulation to obliterate these varices, as the retrograde approach is not feasible. Then coming to the venous inflow. So this classification talks about the inflow. If we have a single dominant afferent from the portosplenic axis, we inject the sclerosant via the retrograde route, and the endpoint would be when the sclerosant starts spilling into the afferent and into the portal circulation, and there we stop. But in case it's a type 2 and we have two feeders, it might be a problem. Why? Because once we are injecting and we reach an endpoint and we see that there is reflux into one of the collaterals or one of the afferents, we might want to stop. But actually, uphill there are more varices, and based on if these two are not at the same pressure level, one of them will opacify first and the procedure will not be complete. In this scenario, we might want to do a staged procedure. A two-stage BRTO could be done in such a scenario, or we might want to look at these individually on the pre-procedure CT and deal with them one by one. In type 3, we can have an afferent draining directly into the shunt and not into the varices. So in this case also, we have to identify this anatomy, and we have to ensure that our balloon is positioned higher to the location of insertion of this afferent into the shunt, and to avoid failures. So coming to the steps, access, it has to be a transvenous access. Most commonly the femoral or the jugular. We might want to use both in a lot of cases, and we tend to use both because that makes our life easier, as I'll show. And then we have selective catheterization of the shunt, which is required. We have to advance our sheaths into the shunt, and then we do a balloon occluded retrograde venography, where we have to identify and occlude collaterals, estimate the amount of sclerosant which is to be injected, and hence injection of the sclerosant, usually using a microcatheter through the balloon catheter. And then we administer the sclerosant. We'll talk about the mixture, and then we do a cone beam CT or a dyna CT on table to look for the completeness of the procedure. The indwelling time would be somewhere around 4 to 24 hours. Typically, we do it in the evening and look at the patient in the morning, generally after 12 hours. But people have described 4 to 24 hours as the stipulated indwelling time. And then we deflate the balloon catheter looking for the stability of the cast. So just a case to show, these are the varices, and that's the shunt going up the varices. We have taken a transjugular axis, that's our sheath. This is our balloon catheter. This is the balloon occlusion venogram, retrograde venography, where we can see collaterals, and these have been embolized using coils and glue and gel foam, and all of them have to be dealt with before we finally start injecting the sclerosant mixture, which is a 3:2:1 mixture. So 3 parts of air, 2 parts of sclerosant, which is generally sodium tetradecyl sulfate, and then 1 part of lipiodol. So sclerosant STS is a soap and lipiodol is an oil. They form a good emulsion. With this combination that we use the Tesserae technique to prepare it, and then we start injecting. So we have already estimated roughly the amount of sclerosant which has to be injected using the occluded balloon venography, but otherwise also we can start injecting and look at the opacification of the varices, gastric varices, and once we achieve completeness, which will be documented by reflux of sclerosant into the afferent, then we stop. And this is the next day we can see that these are the casts of the sclerosant. So another one where we had, okay, first of all, the follow-up, we can see the cast on the CT, and we can see nice obliteration of the varices. Okay, this is the second case where we had a large splenorenal shunt, and so we've used the transfemoral route and we have cannulated the shunt, and then we see that there are collaterals which are small ones and were embolized using gel foam slurry. And then once that's done, we take the balloon and take a venogram, and then we start injecting sclerosant. Once we see that there are no other collaterals to be dealt with, we are injecting the sclerosant mixture, and we leave it, and that's the cast. So these are the balloon catheters which can be used. This is the Coda balloon from Cook. That's the Equalizer from Boston, and Reliant from Medtronic. These are all latex balloons, compliant balloons. We can also use the biliary balloons. The issue is of balloon rupture, which can happen with the sclerosant coming in contact with the balloon. And to deal with this problem, what we do is we generally inject gel foam slurry just above the balloon, and then we try to cannulate. So this was a case of encephalopathy, but in case we are doing varices, we would want to go very high up into the gastric varices and inject the sclerosant on top rather than start injecting from here. And we would rather first inject gel foam slurry on top of the balloon to keep the sclerosant as far away from the balloon as possible. But once in a while, balloon ruptures do happen and have been described in literature. And hence the technique was modified, and we have now shifted largely to plug-assisted retrograde transvenous obliteration, or PARTO, where we use plugs instead of balloon, and we can just deploy the plug and come out. Rest of the procedure remains the same. There is no indwelling time, there is no ICU stay required. And the plugs can be, they are available up to 24 mm. And the upsizing which we require in comparison to the shunt is generally 30 to 50%, and hence we can't deal with more than 18 mm thickness shunts using plugs. Although people have described using side-by-side plugs as well. And then CARTO is another variant where we deploy large coils. So it can be CARTO type 1 or type 2. In type 1, we are using 2 catheters. That's a microcatheter for sclerosant injection, and that's the microcatheter for coil deployment. And the other one would be the type 2, where we carry out the BRTO as we described. And while coming out, we just put coils and just take out the balloon to avoid the indwelling time. And these are the various plugs which are available. The Sera plugs, the Life Tech plugs are this one. The shape is different from the Amplatzer vascular plug which we commonly use. That's the Amplatzer 2. And these plugs are available up to 24 mm, and large sheets need to be advanced into the shunt before deployment of the plugs to ensure correct deployment. So there has to be, so what we do is we look for the narrowest point in the shunt and we use that for deployment of the plug. So in some cases, we might require multiple plugs and multiple coils to reach stasis. And so here we can see this was one plug which was not appropriately oversized, and hence there is no neck formation. It's like a cube. It's like a cylinder, I'm sorry. But when the plug is appropriately sized, it forms this nice shape across the choke point or the narrowest point, as I talked about. It has to be deployed across the narrowest point in the shunt, and then we can achieve stasis. Post-procedure follow-up, we have to subject the patients to endoscopy because we have to look for worsening esophageal varices, which can occur later. And then we have to do an imaging. It can be on-table Dyna CT, it can be a non-contrast CT to look for casts within the lipidol casts within the varices and look for completeness. Ultrasound abdomen just to look for any worsening ascites or pleural effusion as an evidence of worsening portal hypertension. Adverse events, recurrence is one. Recurrence of symptomatic portal hypertension can occur and will lead to worsening varices and ascites, have been reported in up to 40% and 30% respectively. But in cases of balloon rupture, it can go bad. We can have these complications: hemolysis, hematuria, renal failure. With the reflux of sclerosant into the systemic vein, we can have pulmonary embolism, cardiogenic shock, and DIC as well. Access site complications, because these large balloons require large sheets. The Coda balloon requires a 14-French access sheet, and so we have to manage the puncture sites well. Otherwise, with these patients of chronic liver disease with deranged coagulation, puncture site complications and hematomas can happen. Then coming to when to use TIPS and when to use BRTO. So this is a very good classification based on anatomic considerations by Saad Caldwell, where they've talked about the various anatomic variants based on esophageal and gastric and gastroesophageal varices and the feeders, and when to choose which procedure, although it's not such a simple algorithm, but one can refer to these if needed. So by and large, for gastric variceal bleeding, TIPS and BRTO, antegrade and retrograde, both approaches are available. When do we choose? When we have esophageal varices accompanying gastric varices, we might want to use TIPS, but only if the MELD score is less than 19. Otherwise, patients can go into decompensation. Otherwise, an endoscopic approach for esophageal varices combined with BRTO does well as well. And then we have patients where we have intractable ascites or hydrothorax. In these patients, again, we are looking at worsening ascites and portal hypertension sometimes after BRTO. So we would want to do a TIPS if the MELD score is favorable. And in cases of portal vein thrombosis, we might want to defer BRTO, and we might want to first recanalize the portal vein and then do a BRTO. Then recurrent hepatic encephalopathy, mostly due to a failing liver, transplant is the ultimate therapy. But in case we have a spontaneous portal systemic shunt, we must occlude it via retrograde or antegrade route. If the patient has a previous tips, we might want to reduce or occlude the tips. And these are the poor prognostic markers where we have to avoid doing retrograde occlusions in cases of recurrent HE when the CTP is poor and the MELD is poor. And thank you.
Thank you, Anurag Mahendrita. That was such an extensive and enlightening talk. Now we have Dr. Eira. Dr. Eira will be talking on splenic artery embolization. Over to you, Dr. Eira M. Hitalmani.
Yeah, I hope everyone can hear me and see my slides.
Yes, sir, we can hear you and see the slides.
Okay, so I'll be talking on splenic artery embolization, and I will limit the indications to only the cirrhosis and portal hypertension and gastric varices. Okay, so to start with, how actually the splenic artery embolization for these indications started. It started with complete splenic artery embolization, where you sort of block both the superior and inferior ports. Then people started doing one-time partial splenic embolizations. Then there were some complications with that also. So they started doing stage partial splenic embolizations, wherein you do a splenic embolization once, then you wait for a month, see how the patient progresses, then you tackle some more percentage of the splenic function. So what are the indications? The indications for partial splenic embolization include these chronic liver disease of different etiologies. So it can be applicable to all other etiologies also, which lead to portal hypertension. And a lot of times, portal hypertension and splenomegaly, there is no clear explained cause for splenomegaly. But then we do have to tackle that splenomegaly. So portal hypertension can result in this variceal bleeding as well as portal hypertensive gastropathy. So another frequent complication of actually pancreatitis, but it does present as gastric varices, is the sinistral portal hypertension. Certain cases in post-transplant cases where you will have splenic stale syndrome, you will have to use the partial splenic embolization. And it also acts as a preoperative embolization strategy in splenectomy in certain patients who need to be optimized for splenectomy. Few other indications apart from these chronic liver disease are renal insufficiency, thalassemia, and chronic idiopathic thrombocytopenic purpura. So what are the contraindications? First of all, the partial splenic embolization causes decreased portal venous flow, can actually cause portal and splenic vein thrombosis, which is again devastating. So we'll have to be careful in such patients and not do it. And there are certain other relative contraindications, abnormal coagulation parameters, and then decompensated liver disease in its terminal stage, where it is not so prudent to perform another procedure where the patient is already having a lot of complications from cirrhosis. So what are the clinical features of hypersplenism? It is very important to recognize hypersplenism and diagnose the causes for it. So hypersplenism refers to splenic pruning of the WBCs or sequestration of blood cells into the degree such that it causes one or more cytopenias such as anemia, leukopenia, and thrombocytopenia. And there can be compensatory bone marrow hyperplasia. So typically, these cytopenias may not require any, they are so mild that they don't require transfusions. And spleen is often enlarged, but splenism can exist separately apart from splenomegaly. And bleeding due to thrombocytopenia is rare in these patients, in cirrhotic patients, because of reorganized homeostasis. And you may not have bleeding even if the platelets are less than like 10,000 or even beyond that. So in hypersplenism patients, clinically, I'll just give a brief about how they are managed. Patients with significant splenomegaly, we have to ask them to avoid high impact activities, and then we should ask them to reduce the risk of falls. And it is important to treat other cytopenias such as the iron deficiency anemias, vitamin B12, folate, or autoimmune destructions, and bone marrow abnormalities per se. So the first line surgical management earlier was the splenectomy. Most studies have reported a better reduction in cytopenias in comparison to partial splenic artery embolization. And splenic artery embolization is a newer tool, although it has been around for more than 20 to 30 years. There is evolution in outcomes and how these splenic artery embolization is performed. So, what is the preoperative preparation for go on to splenic artery embolization? Evidence was there for pneumococcal vaccination and H influenza B vaccination, as well as meningococcal vaccination. Certain studies in interventional therapies also advise this, but there is no definite evidence where you have to vaccinate these patients. If at all you want to go ahead and follow this, you will have to do vaccination at least 2 weeks before the planned procedure, that is the partial splenic embolization, or in the event of emergency such as the emergent gastric variceal bleeding, you can go ahead with the procedure, and then 2 weeks after the procedure, you have to vaccinate the patient. And again, broad antibiotics are prescribed before the procedure. Again, there is no evidence to this. Just because the patients are more prone to infections, you can go ahead with practicing broad spectrum antibiotics. And all the patients should be given proper information to reduce infectious complications, such as they need to wear a proper mask, N95 mask, and protect themselves from other infectious causes. So what are the investigations that you should do? The routine investigations like CBC, platelet INR, LFTs, and RFTs are essential. Peripheral smear also I suggest, because we need to rule out other causes like hereditary spherocytosis and all. Bone marrow biopsy is also indicated just to document things. And imaging, at least contrast NRCT is suggested, because it helps in planning the vascular access, how you go about the procedure, what are the different IR tools that you can use for this, and also what exactly is the cause for the variceal bleeding. You can rule out celestial portal hypertension and then go ahead with direct partial splenic embolization. Otherwise, you'll just be looking for other treatments such as TAPes, BRTO, but the patient would only benefit from splenic artery embolization. And to plan vascular access, do the ultrasound screening of both femoral as well as brachial and radial approaches. If you are going for radial approach, always perform a modified Barbu test. It is just an improved version of Allen's test. Okay, so in the pre-op CT, it is always necessary to see how your splenic artery anatomy is. In this particular patient, notice that the splenic artery is arising from SMA. Otherwise, you will be looking at celiac artery and searching for the splenic artery, but you wouldn't find it. So, and then the sagittal MIP images help us in choosing which catheter to go. See, in this case, there is acute angulation of the celiac artery, so you can use a SIM catheter instead of the regular Cobra catheter that you can you usually try. And it also helps us in locating the origin of the celiac artery at which level. So coming to the anatomy, artery, arteria pancreatica magna, and certain pancreatic brachydactylic arteries, because these all confuse us with the splenic normal blush, and we might end up doing non-target embolization at times. So this is an example where the artery to tail of the pancreas is seen supplying here. Sometimes you can confuse it for splenic extra splenic tissue, and then you can think that you end up embolizing it. And spleen is one of the best candidates for partial embolizations because it only has got a definitive upper pole artery as well as inferior pole artery, where you go ahead and block only the inferior pole artery to knock off 50% of the blood supply to the spleen. Then coming to what are the tools that are required for procedure, you will need a vascular sheath. Most people prefer a 6 French sheath because you are using a 5 French catheter to place inside that, and then a glide wire to navigate into these 5 French catheters. Once you have super catheter to go into the inferior pole, and finally the embolic agents that will be necessary to go ahead with the partial splenic embolization. So I'll just in brief describe the technique. Most preferred technique is the right femoral artery access. So find the suitable artery for access, and once you have catheterized the right femoral artery, use a selective catheter like the SIM1 and take the celiac artery angiogram. Then you know the anatomy of the splenic artery. Notice that these are the dorsal pancreatic arteries and the arteria pancreatic magna, giving rise to this tail of the pancreas branches. All this is once you have blocked supply to the inferior pole. Some of these can recanalize this inferior pole. That is the reason we are using permanent embolic agents like the PVA particles and gel foam, and not just the coils. So then you go for super selective catheterization after seeing the splenic artery anatomy. So this is these are two videos showing how we are going to navigate a microcatheter. This is the microcatheter into the splenic artery, and this is the micro wire, which helps us go distally into the inferior polar branch of the splenic artery. So this is the angiogram that is taken before you go ahead and start embolization. And it may not be available in most centers, but it is very important to start doing a cone beam CT before you embolize that part of the spleen. So a cone beam CT gives us a brief overview. So when you acquire cone beam CT, you'll get an image like this on your monitor, and then you need another workstation to give you these CT-like images, which actually give you an overview of where exactly you are and how much of the spleen you are going to take down. This also comes with a segmentation software where you can calculate how much percentage of the spleen you are going to knock off. So in this first, in the coronal, we have seen how much of the splenic artery has been embolized already. So this, in this case, we had already embolized about 30%. We wanted to go more. So that is why we wanted to see what other branches are supplying so that we can achieve at least 50% of the embolization of the spleen. So in these situations, as well as to recognize the collateral circulations that happen after some amount of embolization has been performed, are very important. So coming to the embolization aspect. So in the embolization, you will maybe, when you are embolizing, you can use different embolic agents. The example that I have chosen is the liquid embolic agent Onyx. And in this, the liquid embolic agents perform very well when you want to achieve 50% reduction in the splenic function. So this is because we go and block at the sinusoidal level. And even with, I'll be discussing the choice of embolic agents next, but let us see another video where the inferior polar artery was already embolized with some amount of PVA particles. You can see that only the central tissue is enhancing now. The peripheral part of that inferior pole has already gone. And progressively, when you complete your embolization, you take an angiogram from the main selective catheter. You can see that 50% of the spleen is knocked off from the below, and the rest of the 50% of splenic tissue still maintains the maintains its so the choice of embolic agents, see, all of these are permanent embolic agents. It is always important to use either embospheres, PV particles, or liquid embolic agents. And then as an adjunct, you can add coils. The two type of coils, that is the detachable coils and the fibered coils. So when you use fibered coils or detachable coils, if you use them proximally, you may not be able to achieve the reduction of hypersplenism. So you can use them as adjunct to these liquid embolic agents or the PVA particles. And then you can also use amplifier vascular plug to block a very large splenic artery, and then go ahead with adding the particles in avoiding the reducing the function of the spleen. Why use these plugs is sometimes the splenic flow is so fast that you can reflux some amount of the embolic agents. So you reduce PVA particles by placing a microcatheter beyond the vascular plug. So before we go to the complications and management, I just want to touch on what is the post-operative management. So in the post-operative management, what happens is we will need antibiotics, and then the patients complain of a lot of pain, which is a part of the post-embolization syndrome spectrum. You can manage that pain with either a buprenorphine patch or as an expectant management, and then you can add paracetamol infusions, and you can also give patient-controlled analgesias. So in case the patient has got certain complications, you will have to do CCT on the next day of the procedure to see how much of the spleen has infected, how much of splenic abscess is there, and how much of some of the major complications of splenic embolization are splenic abscess, splenic rupture, paralytic ileus, septicemia, pancreatitis, pleural effusion, pneumonia. So all these are some of them are a spectrum of reactive pleural effusion and pneumonia, and even the paralytic ileus is reactive. These things can be managed in the ICU settings with expectant management, and septicemia has to be managed with by stepping up the antibiotics, and splenic abscess and rupture may need immediate surgical treatment by splenectomy. And coming to the minor complications such as the post-embolization syndrome and the abdominal pain, I already mentioned how to manage them. So this is one study where they reported these complications and how they manage them. So you can see most of them you can manage with splenectomy, and they may not thoracentesis, but if there is a large pleural effusion, it might need thoracentesis. And certain cases of thrombosis in the portal vein, they can be managed just with anticoagulation. They may not need the mechanical thromboaspiration or any recanalization strategies. And coming to the outcome of these, so splenectomy and splenic embolization are to be compared. So splenectomy, in the initial meta-analysis studies, it showed better improvement in the cytopenias. With the improvement in technique of the partial splenic embolization, it is also equally efficacious in treating the cytopenias. And then this has got a lesser procedural time and lesser average length of stay in the hospital and less amount of bleeding, whereas splenectomy has got higher mortality with increased risk of bleeding and longer stay. So this is one of the first meta-analysis that was done in 2017. It included about 10 studies and 737 patients. This study only mentioned that the splenectomy has got better outcome, better improvement in the outcomes. However, this is another meta-analysis which was published in 2021 with 21 studies and 1,850 patients. So in this study, you can see that the partial splenic embolization had similar efficacy with splenectomy, improving the post-operative platelet, WBC, and hemoglobin levels. So certain tips and tricks. The most important thing is the tortuosity of the splenic artery that helps us in decide which embolic agent to choose and how to go about it. So whenever you are choosing proximal embolization of the splenic artery, use detachable coils because you might need larger 3-5 systems and you have to be precise. If you don't properly size the coils, they might fly off into the other branches, and it might go and occlude the pancreatic branches also, which leads to devastating ischemic pancreatitis. And for distal embolization, you can freely use the pushable coils, and that is very easy. So the coils have the tendency to migrate. So if you are not able to use the coils, you can use the plugs. But if the tortuous splenic artery is there, I'll tell you how to navigate even for the plugs. Should always be oversized up to 50 to 60%. Usually, because certain times the splenic artery is there in spasm. Eventually, when the spasm is relieved, you may not be able to achieve complete splenic artery embolization. And if you are planning proximal embolization, you can use AVP2, which comes up to 16 into 18 mm, and AVP4 can be used for distal branches, such as the inferior polar artery, where you can use you get AVP4 up to 8 mm size. So this is how we can navigate a tortuous splenic artery. This is adapted from our mechanical thrombectomy, where we use a biaxial system of a long sheath and then a distal access catheter. So you can either use a biaxial system like this to go into the tortuous splenic artery, or use a triaxial system like this, where you use a long sheath and then you use a distal access catheter, and then finally your diagnostic catheter can be taken like a 5 French catheter. And through this, you can either directly take a catheter or a micro catheter, through which you will perform your operation. That's it. Thank you so much.
Thank you, Dr. Eira, for such an extensive and talk on splenic artery with such details. Now, I request Dr. Ved Kakulo to speak on imaging in HCC and surveillance. Over to you, Dr. Ved.
Yeah, hello. Yeah, Dr. Prajit, am
You are
I
audible.
audible?
You are audible.
Yeah, okay. So I'll start with my topic. So my topic is HCC and surveillance. I'm Dr. Ved, and I thank the organizers for giving me the opportunity to speak on this. So I've kept it very short and sweet. So I won't waste much of your time. So starting with HCC, 85 to 90% of all primary liver cancers are HCC. And the statistics say that 500,000 people get this yearly. Now, it's mostly diagnosed in a stage where it cannot be cured in a curative stage. So the 5-year survival is less than 5%. So, but if you catch it in the early stage, then there is potential curative therapy, which is liver transplant, surgical resection, and we should be very proud that many studies are saying ablation is almost equal to, or equal to, in fact, surgical resection. So with a 5-year survival rate of 40 to 70%. This is where we come. It's very important we catch it in the early stage. Now, a short thing about the pathogenesis. So cirrhosis precedes HCC in 80 to 90% of the patients. So this is where surveillance becomes very important, because only 10% of patients with HCC are in a non-cirrhotic liver. So why so? Is because, as we all know, cirrhosis starts with liver injury. Now, what sort of liver injury? I'll talk in the future, meaning in the next slides. So, due to liver inflammation and fibrosis, there is disordered liver architecture. Okay, which means that there are focal areas of abnormal, immature, regenerating hepatocytes. So, if they are like less than 1 millimeter, we call them dysplastic foci. And if they are more than a millimeter, we call it dysplastic nodules. Now, these are the problem creators. Now, in a background of cirrhosis, these are the precancerous lesions, which eventually give rise to HCC. Now, a bit about the pathogenesis. This is a basics. So, all the etiological factors like HBV infection, HCV infection, smoking, alcohol abuse, dietary habits, and then aflatoxin exposure causes steatosis, which is kind of a fatty liver inflammatory state. So then it moves on to stage 2, which is liver fibrosis. And eventually, this is the stage where multiple mutations occur. Now, we should not go too much detail into this, but so somatic mutations like P53, then all that NRAS, EGFR, DRAF, all those then molecular pathways like beta-catenin, tyrosine kinase, all that is involved here, which finally leads to an HCC. Okay, so now this is just a slide which shows how it progresses. So it starts as a dysplastic focus in a cirrhotic liver with a regenerating nodules. It will start as a dysplastic focus, then it will become a dysplastic nodule. Eventually, which is differentiated into low grade and high grade. Eventually, it will become malignant, which is early HCC and progressed HCC. Finally. Now, why surveillance is important is because we need to catch it early. So HCC surveillance recommendations. Now, who is the target audience for this? Since the major etiological factors are hepatitis B and hepatitis C, then next is alcoholic liver disease, and then non-alcoholic fatty liver disease. These give rise to formation and progression of cirrhosis in 80 to 90% of HCC patients. So the 5-year cumulative risk in all these patients is 5 to 30%. So if we kind of want to have a surveillance mechanism, we have to look at the following factors. First is the etiology. So it is highest in HCV, people infected with HCV. So it's important to screen people who are known case of HCV, HBV, or cirrhotic patients, and also ethnicity and region. The HCC is highest in Asians. So based on all this, American Association of Study of Liver Disease and the European Association for the Study of Liver have recommended HCC surveillance for patients at high risk of developing HCC. So now who are these high risk people? Are all these age groups, whatever age groups, or the etiological factors. So hepatitis C, hepatitis B, known case of hemochromatosis, primary biliary cirrhosis, non-alcoholic steatohepatitis, then autoimmune hepatitis. HBV carriers without cirrhosis also are recommended for surveillance. It's not just hepatitis B infected people, but even the carriers are recommended to be surveyed. Then Asian males, as we said, that it's very high in case of Asian population. Asian males more than 40 years, then Asian females more than 50 years, then Africans more than 20 years of age, and those with a family history of HCC. Now, how should the surveillance be performed? Now, the first and the least expensive modality of surveillance is obviously the ultrasound for the radiologist. So this is the primary surveillance modality. Now, its sensitivity is 60% and specificity is 85 to 90%, depending on the experience of the examiner. And these are less accurate in obese and nodular liver. Now, we all know how HCC looks on meaning the abnormal nodule will look on an ultrasound. So early HCCs look hypoechoic, and as they advance because of necrosis and fibrosis and calcifications, they can look heterogeneous, more heterogeneous. So now the most recent guidelines recommend ultrasound for surveillance of HCC as a screening ultrasound every 6 monthly in at-risk group. Now, CT and MRI are not adequately tested for HCC surveillance, but can be used in for surveillance. But the disadvantage is high cost, then radiation exposure. You can't keep on doing 6 monthly CTs and MRIs for a patient for just for the sake of detecting an HCC when we have not found anything. So, and contrast related injury. So CT and MRI are effectively ruled out as a screening tool. Now coming to the biochemical markers, AFP measurement. Now what exactly is AFP? AFP is also, the full form is alpha fetoprotein. Now it's a glycoprotein which is found produced by the yolk sac in the embryo and in the embryonic liver. Now, this is seen to be elevated in HCC, and but the problem is this AFP alone without liver ultrasound is not recommended. Why? Is because of its low sensitivity and low specificity. So even if you take the cutoff of in elevated AFP as 20 nanograms per ml, the sensitivity varies from 25 to 60%. So it is very varied. So we can't just use AFP as a tool. Now, the second problem with AFP is it is not specific for liver per se. Patients with just chronic liver disease who have high degree of hepatocyte regeneration will show AFP elevation in the absence of malignancy. Also, AFP is raised in any inflammation like chronic hepatitis B, even in cirrhosis. Now, AFP can also be raised in yolk sac tumors, and AFP is also raised in pregnancy since it is produced by the embryo. Now, a recent study or multiple studies have shown that 1/3 of patients with HCC have AFP levels higher than 100 nanogram per ml, which is very not very sensitive. So the American Association for Study of Liver Disease does not recommend AFP for surveillance and diagnosis as a sole modality. So now going on to the next test. So this is something which is upcoming. This is called as this gamma carboxyprothrombin, or also called as PUCA. Now, what is the full form of PUCA? We have just been hearing this a lot. So it is protein induced by vitamin K absence, and they have abbreviated it and made it PUCA. Now, what exactly is PUCA? PUCA is an abnormal prothrombin. It is basically a precursor of prothrombin, coagulation pathway prothrombin. Now, we should not go, it's not necessary for us also to go too much in the detail, but if you, for the exact definition, it is an abnormal prothrombin molecule produced as a consequence of acquired defect in post-translational carboxylation of prothrombin precursor in malignant cells. So this all, the end, this is, it is produced by malignant cells. That's it. We should just remember that. And another test which has recently come into play is lecithin bound AFP, which is also called as AFP-L3. Now, what exactly is lecithin bound AFP? Now, AFP, based on its binding capacity to this protein, sorry, I'm very sorry, I didn't mean lecithin, I meant lectin. Okay, so AFP, based on the binding capacity to this protein called lectin, is differentiated into three parts, three types. So there is one AFP L1, which is elevated in chronic hepatitis B and cirrhosis. AFP L2 is elevated in yolk sac tumors and pregnancy. Now, AFP-L3, they say, is specific for malignant hepatocytes because the AFP, which is produced by malignant hepatocytes, has a very high binding capacity to this lectin. So this is now upcoming, but it is still under, as you say, kind of studies. There are studies which are going on. Recent study in 2022, which is just last year, showed that 30% of AFP cases, HCC cases, AFP-L3 gets elevated. So we still have to see how maybe it will be upcoming in the future. And that is why the evidence is inconclusive, whether these biomarkers perform better than AFP for detecting HCC. Not only that, even the combination of all these markers, if you take AFP, AFP-L3 and PUCA, it only marginally improves the accuracy for early detection of HCC. And so the current recommendation for screening these patients is a combination of liver ultrasound and serum alpha fetoprotein. Now, summarizing everything, this is the most important table of my entire surveillance. Now, this is something which will commonly come across clinically. Like just that day, I had a patient who had a cirrhotic patient with 2 nodules in the on ultrasound, which are around 13 mm. So this table really helped me on how to go about with the patient. It was referred to me by a gastroenterologist. So if we just look at this, now this is a table which is taken by combination of various guidelines, and this is being used by gastroenterology, Journal of Therapeutic Gastroenterology, which is found by this American Department of Veterans. So they use this to screen veterans for HCCs. Now, say we get a liver mass on an ultrasound in a patient with cirrhosis. Now, what to do? How to go about it? Is if the mass is less than 1 centimeter, they are saying you just follow it up. Now, follow it up meaning repeat imaging every 3 to 4 months, meaning repeat ultrasound every 3 months. And if you see no growth in 1 to 2 years, then you don't take it as a HCC, and you continue routine screening for these patients. Now, if you see a growth, they are saying you directly treat it as a HCC. No, don't even have to do AFP or any of that. Now, if the mass is 1 to 2 centimeter, for diagnosis, what you will do is they are suggesting 2 dynamic imaging studies, CT scan or an MRI. Now, if both show typical vascular pattern of enhancement, which we all know it is early enhancement in the early arterial phase and washout in the venous phase, then you should treat it as HCC. And then this is if both show. Now, if one or both are showing atypical type of enhancement, which is not typical of this HCC, then they are recommending biopsy of the mass. So now if biopsy confirms it as an HCC, then obviously you treat it as an HCC. Now, if biopsy comes non-diagnostic, you do repeat imaging study every 3 months. Now we go back to the above follow-up. So if there is no growth in 1 to 2 years, we don't call it, meaning we assume it is not HCC and we continue our routine screening. Now, if we see that it is growing, then you treat it as an HCC. Coming to masses more than 2 centimeters in a cirrhotic liver, for diagnosis, you use only one dynamic imaging study, either a contrast enhanced ultrasound or a CT or an MRI with contrast. And if you see a typical vascular pattern, which is enhancement in the arterial and washout in the venous, you directly treat it as an HCC. Now, if you see a atypical vascular pattern here, which is not very characteristic of HCCs, and the mass is more than 2 centimeters, this is where your AFP comes in role. So if AFP is less than 200, that is the cutoff which is recommended, then you do biopsy of the mass. If AFP is more than 200 and the mass is more than 2 centimeters and it is showing a atypical vascular pattern, we can still treat it as an HCC. So this is where your AFP actually comes in the role. And for follow-up, if the biopsy confirms with HCC, then you start treating it as an HCC. And if this also is non-diagnostic, then you do repeat imaging study every 3 months. If no growth is there, then you take it as not an HCC. If there is a growth, then you treat it as an HCC. So these are my references. So all this, this surveillance is a topic which is very, there are multiple guidelines, but I think this is from Journal of Therapeutic Advanced Gastroenterology, and this is the most reliable surveillance technique which I found after doing extensive research. Yeah. So thank you.
Thank you so much, Dr. Ved. It was such an extensive talk, and you have covered the entire surveillance part in such a short time. Thank you so much for that. Now we have Dr. Sabarish, who will be talking TACE and microwave ablation. Since he has to leave for some emergency work, so he will be doing now. So I welcome you, Dr. Sabarish. Over to you.
Yeah, thank you so much. So I will be sharing my slide. 1 minute. Share screen. Just a minute. Display. What is it? Mhm. Basically. So 1 minute, just I'm not able to share my file.
No problem. Are you using Mac?
Yeah, I'm using Mac.
You'll have to give authentication, I suppose.
It's coming general file. Privacy. Little பண்ணலாமா? Just give me a sec, 1 second. 1 minute, sir. Dr. Prijit, just a second. I will open in another system.
Okay, no problem. Since there are some technical glitches from Dr. Sabrish's side, now we'll have Dr. Anirban who will be speaking on the topic BCLC. It's one of the most important topic when it comes to hepatocellular carcinoma and treatment. So over to you, Dr. Anirban. I have to remove this side. Good afternoon, everyone. Am I audible? So I am Dr. Anirban from Narayana Hospital. A special note of thanks to my immediate senior, Dr. Prajvit, for inducing me for this topic. Now, my topic is Barcelona clinic liver cancer. Of course, it's a topic which is based on classification, and it's supposedly not the most interesting part, but nonetheless, without further ado, I shall begin. So, but BCLC, as we know it as, is a part of the clinical staging systems. The first staging system which was introduced was the Okuda system, or the Okuda classification, which was introduced in Japan in the year 1985, which I believe so. It was a simplistic classification, which was further modified and upgraded as the CLIP, or the Cancer for Liver Italian program. But here we are concerned with BCLC. So why is the world fixated for this particular classification system? It is because it's a very important prognostic tool. It helps the clinicians in making clinical decisions as regards to the patient's treatment algorithm. Now, it's based on certain parameters which we are all well aware of. The Child-Pugh score to begin with. It's also based upon the size of the tumor, the numbers, the number of lesions, if it's a multinodular or a multilesionar HCC. Certainly, whether it has got the HCC has any vascular invasion or extrahepatic spread. But most importantly, it incorporates the performance status, which was missing or lacking in the previous classification or the staging systems. The performance status is something which we are aware of. I will be discussing this in the coming slides. So I'm not pushing much for the Child-Pugh score, which we are all aware of, and it has been discussed, I believe, by Dr. Aditya as well. So just to go along with the parameters, we look into the serum bilirubin, albumin, INR, encephalopathy, as well as ascites. And we classify the patients by the addition of the points, the class A being the best the best, while the class C being the worst, the patients with the worst outcome. Now, the ECOG performance scale is one which has been incorporated into the BCLC, which makes it, like, as I mentioned it earlier, the one with the means that by which we can basically assess clinically assess the patient. It helps in that algorithm. So 0 stands for the asymptomatic patients, the patients who have malignancy but are asymptomatic. 1, the patients are symptomatic but are able to perform the lighter activities, not the physically strenuous ones. 2 being symptomatic again, but are generally in a state where they can take care of themselves. I mean, the personal care is done by themselves and confined to bed or the chair for less than 50% of waking hours. 3, where they are symptomatic certainly, and certainly the degree or the severity of the disease load increases, and they are confined to the bed for more than 50 hours, 50% of the waking hours, and capable of only limited self-care. 4 is the one where they are completely bed-bound, that is completely disabled. And 5, of course, is ones who have expired. So the BCLC algorithm, this is the algorithm which is the simplistic version. I will be coming to the updated version, which is being used nowadays. So just to mention the basic points, the stage 0 is the very early stage. As you can see, the performance status is 0. The Child-Pugh classification is A. It is the single most defining factor is that a solitary lesion has to be there, which is less than 2 centimeters in size. Of course, the standard, the best possible treatment is resection. If it is not possible because of portal hypertension or the presence of elevated bilirubin levels, then it's considered to be a contraindication for the same. So the patient is considered either for a transplantation or an ablation. The transplantation can be done
with only if certain comorbidities are not there in the patient, like diabetes, hypertension, coexisting coronary arterial diseases and such, then the patient is considered for ablation. The stage A is like, again, the PS is 0, the performance status is 0, the Child-Pugh A to B. It is applicable for a solitary lesion which is less than 5 centimeter in size, or multifocal disease, which are like they can be up to 3 lesions, all less than 3 centimeter in size. So the management is like the solitary, it is like if it is possible for resection, then go ahead. If at all resection is not possible, then the patient, or else the patient has multinodularity, then the patient is considered for transplant or ablation. Depending upon, again, going by the same criteria, if the patient is not fit for transplantation due to the comorbidities, then the patient is considered for ablation. The stage B, the intermediate stage, where we have moved into the multinodularity or the multifocality of the disease to a great extent, where if more than 3 number of lesions, or at least 1 lesion which is or more than 1 lesion which are over 3 centimeter in size. The management which was prescribed in these stages was like simple, the transarterial chemoembolization. Stage C is one where, as you must have noticed, the performance status has been elevated to 1 to 2, Child-Pugh is A to B again, and it is defined by when the patients have vascular invasion, primarily the portal vein, and of course any kind of other close by vascular structures, and or the presence of extrahepatic spread, which might be the portal lymph nodes and others. The treatment was simple. In a simplistic term, it was a systemic therapy that is primarily based upon the usage of sorafenib. And the last stage was the end stage disease, which is the performance status can be 3 to 4 and the Child-Pugh C. The patient was considered for the basic support care or the symptomatic treatment only. Now, the critical analysis was that over the years when the BCLC was developed, the medical technologies and the various data which were coming out from journals and research as suggested that it needed some reorientation, or rather subgrouping of certain stages, particularly stage B and C, because there was a lot of heterogeneity to the groups. It was seen that though the suggested treatment for the stage B was supposedly TACE and stage C was systemic, but there were certain advances in surgical treatments and all, which certainly necessitated the need to further subgroup or subclassify the system. So now we move on to the BCLC 2022 updates, which are primarily based upon the basic structure has not been tampered with, but several additional points have been incorporated. So the salient features are, for prognosis assessment, albumin, bilirubin score, and AFP values have been included for the assessment of the liver function, in addition to the other parameters which are already there. Very importantly, clinical decision-making should not be confined only to interpreting the various values and the biochemistry parameters. It should be a multidisciplinary approach based upon consultation with a lot of, other disciplines as well. 2 important points which I would like to lay special emphasis on, which includes treatment stage migration and untreatable progression. The treatment stage migration, as you can see, is defined as the first line therapy for a stage is not feasible because of patient's condition. The next most feasible option within the same stage or a more advanced stage should be considered. I have not tampered with the basic definition of this. And certainly also the same applies to untreatable progression, when either treatment failure or progression after the selected treatment approach occur, but the patient, it's not feasible or it's not successful, but the patient's general condition is still fit enough to be in the original stage, then the next most advanced therapy, the next therapy for a more advanced stage is considered. So the major update involves or incorporates the stage B, which is, as I was telling you, there was a lot of heterogeneity to stage B. What is it? It is basically has been subclassified into 3 groups. The first one being multiple nodules. And if the patients or are basically fit enough to be, considered for extended liver transplant, which includes AFP status and the whole of the tumor burden, then they should be considered for transplant. The second subclassification of the subgroup involves patients who have exceeded the criteria for an extended LT or the liver transplant, but have preserved portal flow and a well-defined tumor burden, and obviously an adequate liver function. And a third subgroup is the one who have a presence of a diffuse disease and an infiltrative disease, but still are generally asymptomatic and have a preserved liver function. Another major update has been in the systemic therapy. Earlier, the classification, the BCLC was based on the consideration of sorafenib or lenvatinib. Now it has been, as you might have noted, I have put in the trials, the I Am Brave trials, 150 trial. The atezolizumab and the bevakizumab have been found, this combination of drugs has been found to be superior to sorafenib for first-line therapy. More recently, in another trial, the tremelimumab and durvalumab, administered every 4 weeks, has also been found to be superior. Of course, there was another trial, yet another trial in China, which is still in this phase 2 and phase 3, so I won't be talking much about it. But certainly the place of, or the, the sorafenib or lenvatinib are not lost completely. There are many considerations which have to be taken, as already spoken about, within a multidisciplinary approach. Many of the patients suffer from toxicity induced by atezolizumab as well as bevakizumab and the treme and the durva combination. For such patients, sorafenib and lenvatinib should also should be continued to be considered as a first-line drug. So, few additional points. Based on legacy trial, the importance of tear has also been recognized, particularly those who fail to show adequate amount of response in a very early or the early stage to either ablation, resection, or transplant. Tear should be considered, provided the single tumor less than 8 centimeter criteria is fulfilled. The second major concept has been the tumor downstaging, where it has been primarily for the intermediate stage, where the goal of the downstaging is to use a particular sort of a treatment so as to reduce the tumor burden and the other parameters, so that the patient can fit into the Milan criteria to undergo LT. And of course, the third one, which I have discussed in a modified version, is like this. There is no place for only relying on biochemical or radiological parameters. One has to take in a very personalized decision based on tumor board recommendations. So coming to the last parts, I have color coded the boxes. The gray boxes are consistent with the earlier BCLC. The blue colored boxes are the ones which you are displaying on your screen, are the ones which are the additional points which have been upgraded in that, incorporated into the 2022 upgrade. So as you might see, for the very early stage and the early stage, ablation, resection, and all, this flow chart, if expected survival is 5 years or above, if the expected survival is not happening or there is non-feasibility, then the patient should be or can be considered to be tear. We already know the systems like a single lesion or a multiple nodularity of the lesion. The tear can only be considered if it is a single lesion less than 8 centimeter. Again, there is as already mentioned, the treatment stage progression. You must remember this term. If at all the patient is not responsive to tear, then the next feasible treatment is the systemic treatment. Again, if it is not possible and the patient fulfills the criteria of the TSM, the treatment stage progression, then you have no choice but to go for the basic supportive care. That's the symptomatic treatment only. This slide basically deals with that intermediate stage, advanced stage, and the terminal stage. Again, the color coding follow this. The gray ones are the older versions which have not been tampered with, while the blue ones are the 2022 updates. The 3 subgroupings, as I have already talked about. The extended liver transplant criteria, if they fulfill, they are to go for transplant. Expected survival is more than 5 years. If they are well-defined nodules, but with preserved portal flow, then the patient is to be considered for TACE. Here, the main objective of TACE is not to completely alleviate. There is a secondary objective is to downgrade the tumor and to make the patient free or responsive to transplant, fitting the Milan criteria. If at all that is not achievable, then we follow the treatment stage migration pattern and head the patient or ask the patient to go for the systemic treatment. And the third subgrouping, as you can see, the diffuse infiltrative that I already described about, directly goes into the systemic treatment. So which falls under the purview of the advanced stage, which is like portal venous invasion, extrahepatic spread, and the performance status is 1 to 2. Expected survival for systemic treatment is more than 2 years. Again, if it is not feasible or failure, then there is no other choice but to go for the best supportive care, which is like the recommended treatment, which remains unchanged in case of like earlier BCLC versions as well as the 2022 version for the terminal stage of tumor. So this was all about it. It's a bit complicated, but hopefully, I mean, you must have gotten some of the basic points. Thank you.
Thank you, Dr. Anirban. That was such a difficult topic, but you made it so easy for us. Thank you. That was great listening to you. Okay. Now we will go to Dr. Sabrish for his talk on tear and microwave ablation. Over to you, Dr. Sabrish.
Sir, I'm sharing the screen from my end.
Yeah, okay. Thank you. You're on mute now.
Yeah, okay, sir.
Can hear
Thank
you.
you.
Yeah.
So, able to see my screen?
Yes, we can see your screen.
Okay, so thank you so much. I'm so happy to be a part of this hepatobiliary intervention. Dr. Prajwit Rai, thank you for the opportunity. By this, we are going to start a brief look to our case tear. Yeah, tear means transarterial radioembolization. So just a small introduction. TARE is a minimally invasive procedure that combines embolization and radiation therapy to target liver tumors. So we are just going to deal with in detail. So we can always say that TARE is also known as selective internal radiation therapy, which involves delivering of the high doses of radiation directly to the liver tumor while minimizing damage to the healthy liver tissue. So this is how this has been achieved by injecting the radioactive microsphere yttrium-90 into the hepatic artery, the main blood supply to the liver. The microspheres lodge into the liver tumor blood vessels, delivering localized radiation therapy to destroy the cancer cell. So the tear is suitable for whom or what are the criteria for tear? Is the main thing is primary liver cancer, any type of primary liver cancer, hepatocellular carcinoma, metastatic liver tumors from a colorectal cancer or other primary tumors, inoperable cases like patient who can't undergo surgery due to tumor size, location, or underlying health condition is suitable for tear. So as I was a part of TATA, so in TATA, we always have a tumor board. Tumor board includes surgeon, intervention radiologist, medical oncologist, and radiation oncologist. So the combination of these faculties will make the proper decision what sort of treatment should be given to the patient. So from the intervention radiology part, we will be always consider with ablation, which can be thermal or non-thermal, or transarterial therapies like TACE, TARE, or portal vein embolization. So as we all, the previous speaker has talked about BCLC classification. I'm not going in detail of that. And here we can see that what are the stages where we will consider TACE, TARE, and ablations. So to consider what are the various types of embolization we can see here is, here we can see that first one is artery embolization, where we can say that the mechanism is to disruption of the blood supply to the tumor with a particle size of 100 to 300 micrometers. Conventional chemoembolization means we are delivering a high dose of chemotherapy with a lipiodol emulsion, following by the arterial embolization, so that the prevention of washout and maximum radiation, maximum chemo is being given to the tumor with a particle size of 300 to 500 micrometer. So next one is drug-eluting bead chemoembolization. As we all know that the drug is being loaded microspheres that provide local sustained tumor drug therapy combination and leading to the ischemia hypoxia and drug distribution up to 0.06 millimeter from the microspheres and particle sizes 100 to 300 micrometer. Radioembolization is the mechanism of action is delivering of beta emitting microspheres that provide local high dose radiation. The radiation effect tissues is 2.5 to 11 millimeter from the delivered microsphere. Here we can see that the green color and the particle size is 20 to 60 micrometer. So what is the major difference between TACE and TARE, transarterial chemoembolization and transarterial radioembolization? As we see that the ischemia is associated with the TACE. Because we are embolizing that part, but that is been not there with the TARE. Bead size is 100 to 500 microns in TACE, and it is only 30 microns in TARE. There is no radiation in TACE as it is a chemotherapy, and it is a radiotherapy, radioembolization. Definitely TARE consists of radiation. Tumor response is longer in TACE, which is shorter in TARE, and time to progression is short in TACE and which is longer in TARE. Liver function worsening effect and chances of hepatic encephalopathy is much more with the TACE, which is lesser in TARE. So here in the diagrammatic view itself, we can see that the embolization, chemoembolization, we are creating a embolization and we are creating a ischemic event in the case of TACE, whereas we are exactly giving the radiation in the case of TARE. So main consideration of radioembolizing agent yttrium-90, which is having a T-half of 64.2 hours, TerraSpheres glass, which is been loaded, and it will emit the beta radiation, which will cause direct cytotoxic destruction. So inclusion criteria for the TARE is life expectancy more than 3 months, where the patient is not eligible for surgery or not for ablation. We can always consider that. So here we can see that bilobe disease or portal vein thrombosis as well as a large tumor, which we can consider the TARE as a model, treatment option. And exclusion criteria is limited hepatic function with a bilirubin of more than 2, albumin of less than 2.5, BCLC-D, Child-Pugh-C, lung shunt of more than 20%, which is one of the important criteria for considering TARE. Extrahepatic metastasis, and also comes the ECOG, that is the Eastern Cooperative Oncology Group Association. If the score is more than 2, and excessive tumor burden, they are all the exclusion criteria for TARE. So coming to the MAP plan is macro aggregated albumin scintigraphy, which is very, very important prior to the treatment of prior to the startup of the TARE. So the main thing, the planning includes angiography, lung shunting, obtain tumor segmental volume, and dosimetry. So comes the diagnostic angiography is mainly coming to the angiography is mainly to identify any sort of hepatic artery anatomy. Sometimes hepatic artery can be arising from the superior mesenteric artery, variations of hepatic artery or catheter, where exactly we need to place our catheter, because after the placing the catheter only we will start the TARE, we will connect to the yttrium and we will start TARE. So everything to be decided prior to the procedure, and we need to have a look on the shunt. That is one of the very important criteria for TARE. 99 technetium metatable stage macro aggregated albumin scintigraphy. So what we will do is that we will send the patient for mapping. We'll inject the map and we will send for the scintigraphy, and we will see how much is the extra hepatic deposition, how much is the hepatopulmonary, how much is the hepatopulmonary, how much is the hepatopulmonary shunt, and also we will see that what is the lung dosage. Lung dosage maximum of that 30 gray is acceptable. More than that is unacceptable because it can cause severe radiation pneumonitis. And also we can say that the dose absorbed in the lungs due to the shunt can be calculated with a formula here, which has been given. D is equal to gigabels injected into a lung shunt fraction into 50 by m kilograms of the lungs. And then comes the coiling. So most of the cases, I had seen is that we used to do coiling, that is gastroduodenal artery embolization or gastric artery embolization, just to prevent the reflux into these arteries, which can cause severe gastritis or severe forms of ulcers in the bowel. So to prevent that, we always used to coil prior to starting up of the tear. So what happens is that most of the cases we will do this coiling, but if it is straightforward case to avoid non-target embolization, we are doing this. But if the if the catheter is, we are able to take into the straight path to the tumor, or we are able to deliver the drug straightly into the tumor, there is no need of coil embolization as per the recent studies. But if the anatomy, say for example, if the left lobe of the liver we are going to embolize, and the branch of the left near to the hepatic artery comes the gastroduodenal artery, definitely to prevent the reflux of the radioembolization material, we need to embolize this gastroduodenal artery. And here, as we see in this example, we can see that one of the smallest branch also we are embolizing to prevent the this can be the gallbladder branch, cholecystic branch also can be we are embolizing it, and also the GDA branch is also been embolizing prior to the procedure. And assembly, coming to the assembly, we can see this glass box which we are seeing over here, and inside the box consists of we will load the yttrium, and we are having the opening part, and will be connecting a syringe. And how we will inject is that we will slowly inject the saline into the glass shunt up to the time maximum. We will inject slowly 3 times of injection will be injected, so that the drug will be completely loaded into the microcatheter. No drug residues will be lost, and we will completely inject slowly for 3 times, and we will make sure that complete drug is being loaded into the microcatheter, and slowly we'll start embolization. So we will start the radioembolization, so that no drug residue is being lost, or the correct dosage will be delivered into the target tumor. So this is the assembly which we are doing the tear. And also prior to the assembly, we need to make sure that even if some yttrium particles is been spilling, we need to make sure that the floor is covered with papers. And also always we will have a help from the nuclear medicine people to look for any type of radiation is there. We need to assess it. So we always combine tear always will be performed under the supervision of a nuclear medicine specialist. So here comes some of the cases. This is a 33-year-old, about a 33-year-old male patient whose ECOG score was 1. No icterus, there was no mass or no ascites, and HBV related chronic liver disease, hepatocellular carcinomas, which was involved in segment 5, 7 and 8, which is child Puck score of A, 5/15. BCLC was C, and with IBC thrombus. So laboratory parameters, when we are looking on, the bilirubin was 1.3, albumin was 3.6, INR was 1.7, platelet was 167, HbSAg was reactive, serum alpha fetoprotein was higher side, and serum CEA was also on the higher side. So what happens is that we had taken the CT scan. CT scan revealed cirrhotic liver, splenomegaly, and there was enhancing lesion in segment 5, 8, and with right hepatic vein thrombus extending into the IVC, and right portal vein thrombosis. So we had done the tear, and this is a follow-up scan after 1 month. If you are seeing that the lesion which was been completely involving has reduced its size, and necrotization has been started in the follow-up scan after 1 month. So MRI scan after 3 months, we can see that the tumor size has been reduced completely. And pre-tear, we can see that the hepatic vein thrombus, which was not been seen post-tear, at the same time, IVC thrombosis was also completely resolved, and also portal vein thrombosis was also being cleared up post tear. So to conclude that the tear is mainly a bridging therapy for transplantation. The transplant surgeon, if the lesion is 8 centimeter, we always used to ask us to reduce the size of the lesion, so that he will do a surgery, so that the future liver remnant and the tumor's burden will be reduced, and the future liver remnant will be increased, so that he can do a lobectomy, and the patient can FLR will be adequate for the rest of the life of the patient. tear cases large lesion. This is a case in which large right hepatic hepatocellular carcinoma, patient treated with 1 dose of Terasphere, which can see that 2 months follow-up itself, we can see that the reduction in the size of the tumor with the necrosis, and also 8 months post-treatment, we can see that double the size reduction has been seen. And moreover, once we are starting performing the tear, the follow-up should be done 6 months. Then only we can see the big difference, how nicely the tumor burden has been reduced by increasing the FLR. This is another case where a 68-year-old male patient who was a case of type 2 diabetic mellitus and hypertension with chronic alcohol history, which was diagnosed hepatocellular carcinoma during the pandemic time. Triphasic CT was showing a 5.6 into 4.3 into 3.2 centimeter size mass. Portal vein was normal. AFB was 686. And bilirubin was 0.4. INR was 1.2. And PIVKA2, it's a blood investigation specifically to identify hepatocellular carcinoma. When in the case of mixed tumors, HCC is very highly sensitive for this test, which has been done, which was also on the higher side. Viral markers were negative. So the patient was taken, triphasic CT was taken with future liver remnant was only 42%. Just carefully see this case so that the lesion is being seen, and we started the tear. Patient was planned for tear, and all the segments, middle hepatic artery, anterior hepatic artery, posterior hepatic artery was given with a significant dosage, which was being noted and calculated after the MA administration. And then post tear, we always used to take the radiation segmentectomy was done, and post tear we had take the PET scan, which was showing a good distribution, which has been seen in the right and middle hepatic artery. And post tear follow up, we can see that there is a decrease in the size and artery enhancement with the increasing hypoenhancing component and resolution of filling defect, which is being seen in right hepatic vein. And the future liver remnant, which was only 42% has increased into 65%. And following tear follow-up, no intermediate lesion was seen in the T2, and no early enhancement was being seen. And also patient underwent right hepatectomy. And you can see that all margins were free of tumor. Closest margin from the tumor is liver parenchymal cutoff margin, and that was the HP result. And post-tear and hepatectomy follow-up, no obvious enhancing lesion was seen at all. So that is the significance of tear, which will increase, which is a bridging therapy for the surgery. At the same time, it will increase the future liver remnant. But some of the major complications of the tear includes abscess, radiation include cholecystitis, gastritis, pneumonitis, dermatitis, stroke, and hepatic decompensation. When we are exclusively, we should make the point that we should be selectively doing. When non-selective tear in large tumors, there can be a chances of hepatic decompensation. So post-tear, we need to do criteria, dynamic MRI, triphasic CT, and tumor markers. Assessment is done, is best done at 90 days, as necrosis is maximum at this period. So there's a lot of journals regarding this. Response assessment measuring tumor volume, which was 928.5 centimeter pre to the procedure, and post radioembolization, it has reduced to 249 centimeter. So this is the main thing. So here in this journals, which was seen that out of 602 patients, which has been done, our 16 studies, the surgical resection after radioembolization was carried out. And although the available data suggests that radioembolization prior to major hepatectomy is a safe with a promising oncological outcome, the definitive role of radioembolization requires assessment with controlled clinical trials. And also here we can see that injection of yttrium 90 microspheres, the median survival rate of the patient itself is 18.6 to 3.6 months. So the mean survival rate is coming from 16 to 20 months, which is a quite acceptable form, and it is a form of acceptable things. So with this, I would like to say that TARE, which is one of the very important procedure which we need to know. It's somewhat costly procedure, but it is one of the main procedure which has a major role in the case of hepatocellular carcinoma patients. Thank you.
I think you can finish your other topic as well.
Yeah. So my next topic is microwave ablation. basic principles. So what is tumor ablation? Tumor ablation, we can say the direct application of chemical and thermal therapy to a focal tumor tissue to achieve or eradication of or substantial tumor destruction. There can be thermal ablation, can be radiofrequency ablation, microwave ablation, laser ablation, high intensity focused ultrasound, which is known as HIFU. And then comes the cryoablation, that is cold-based ablation with the liquid nitrogen, and chemical ablation with alcohol and acetic acid. So definition related to the ablation techniques is tumor ablation means direct application of chemical or energy-based therapy to substantially destroy tumor tissue. Heat sink effect, buffering effect of patent blood vessels or ventilated bronchi in contact with the targeted area, major source of incomplete tumor ablation. Heat sink effect is very, very important because it can lead to incomplete form of ablation. And tissue impedance is opposition that a specific tissue prevent to current flow and depend on dielectric properties of the tissue. The same thing, ablation shown means the area resulting from the chemical or energy-based treatment, and it should encompass the whole target tumor volume, including circumferential ablation margin. Technical success is when this ablation margin is completely coverage of the tumor by the ablation zone with an adequate ablation margin, and technical failure is incomplete tumor ablation, presence of residual unablated tumor. Technique efficiency means absence of tumor relapse at the ablation site, provided that no residual tumor could be detected by post-procedure image assessment. And local tumor progression means definition by appearance of tumor foci inside or the edge of the ablation zone during image follow-up, provided that complete ablation with adequate margins could be documented with a previous contrast enhanced study. Time to progression is time interval between the treatment initiation and disease progression and measure of technique efficiency. So heat tissue interaction means 45 degrees for several hours, which will cause irreversible damage. 50 to 55 degrees cause irreversibly damage in 4 to 6 minutes. Near immediate coagulation will be achieved in 60 to 100 degrees centigrade, and more than 100 to 100 degrees centigrade tissue vaporizes and carbonizes. So thermal ablation, as we told, there are three forms: radiofrequency ablation, microwave ablation, and cryoablation. Radiofrequency ablation, we are always using electric current will be transformed into heat, which destroys the tumor. Microablation is a form where we are using electromagnetic waves, which destroys the cancer cell. And cryoablation is freezes the tumor with extremely cold temperature. This is a setup. Here it is been shown with the radiofrequency machine. This is a setup how we will treat the case. We will keeping the machine, everything ready. And coming to microwave ablation, microwave energy is subset of radiofrequency spectrum, which will create an electromagnetic field for dielectric heating. What are the major advantages? Major advantages is it's fast and more uniform heating, less dependent on tissue property, and no grounding pad is necessary as it is being used in radiofrequency ablation. Here in the schematic represented itself, you can feel the difference. Okay, in the case when we are using the radiofrequency ablation, we are using the grounding pad. At the same time, the tumor to ablate is here. These are the blood vessels. The heat which is being induced in the tumor will be transferred into the blood vessels because of heat sink effect. And in the case of microwave ablation, the heat sink effect is not there, and the tumor ablation area is somewhat elliptical, and the ablation zone is also been nicely well defined, which is not that defined in the case of radiofrequency ablation. So more uniform method of heating is being shown in the case of microwave ablation. And here, how the microwave ablation is working. Microwave ablation uses electromagnetic methods for inducing tumor destruction using antenna with a frequency between 900 and 2450 megahertz. And microwave ablation works upon two theories, that is dipole theory and ionic theory. Okay, how it is happening is that rotation of dipole molecules, heat generated during microwave ablation. So what happened is water molecules are dipoles with unequal electric charge distribution. So when we are giving the microwave ablation at the same rate, oscillating electric field, therefore electromagnetic waves heat matters by agitating this water molecules will be agitated in the surrounding tissue, which will produce friction and heat, inducing cellular death via coagulation necrosis. So main thing is that in microwave ablation, we are achieving coagulation necrosis. Ionic polarization is ion moves in response to applied electrical field of microwaves. Displacement of ion causes collision with other ions, which will convert kinetic energy into heat, which is being delivered into the tumor. So what are the major disadvantages of microablation is that it is an underpowered system. Shaft heating can be there. So many times it can cause skin burns. Long and relatively thin ablation zone, which has limited clinical application, especially in the case of small bone lesion like osteoblastoma and in the case of solid organ surface lesion. And cost is comparatively higher than radiofrequency ablation. So if we are making a comparison between radiofrequency ablation and microwave ablation, the same thing. Mechanism of radiofrequency ablation is electric current, whereas in the case of microwave ablation, it is electromagnetic energy. The heating is very, very non-uniform in radiofrequency ablation, and it is very uniform in microwave ablation. Procedure time is more in case of radiofrequency ablation, it is less in microwave ablation. Intratumoral temperature is less in RFA and it is more in microwave ablation. Ablation zone is unpredictable, which is predictable in microwave ablation. Heat sink effect, as we had already seen, which is present in radiofrequency ablation, which is less susceptible in the case of microwave ablation. Peri-procedure pain is more with radiofrequency ablation, which is less in microwave ablation. Lesion treated at one time is single in case of radiofrequency ablation, and at the same time, we can see multiple lesions can be treated with microwave ablation. Ablation volume is very, very small in RFA, and it is larger in microwave ablation. Grounding pad is present in RFA, which can lead to thermal burns, which is not used in microwave ablation. So the method of ablation is percutaneous ablation of liver tumor, percutaneous ablation of HCC with artificial pleural effusion, laparoscopic liver tumor ablation, open liver tumor ablation. Other areas is even now the thyroid nodules ablation can also be done with microwave ablation. Since this is completely into hepatobiliary intervention, we will concentrate upon the liver ablations. Okay, so 2012 the CT was showing before ablation. So the ablation was being done continuously. The needle, which can see that the antenna is being placed into the tumor, ablation has been done. And CT, complete ablation, which is being achieved in the ultrasound. And the CT after a month shows that complete necrosis of the tumor, which has been done. In 2016 ablation therapy, we can see that the lesion is been here. And after that, after 2 months, recheck CT was showing that complete necrosis is being achieved. Now, we used to create artificial pleural effusion when the lesion is difficult to assess, or when the lesion is adjacent to the pleura, or when the lesion is adjacent to the diaphragm. So what happens is that we'll always give glucose, 5% glucose being injected, and we'll create an artificial pleural effusion. And as we can see over here, the lesion is over here. We had created an artificial pleural effusion, and the ablation was being done, and we can achieve the we achieved the necrosis of the tumor. And other thing, this is another case where percutaneous ablation with artificial pleural effusion has been created, and we had after the ablation complete necrosis of the lesion 1 month after the ablation has been achieved. And 1 month after TACE, percutaneous ablation with artificial pleural effusion, 1 month after ablation. So combination of TACE and microablation is very, very important. If the lesion is 7 centimeter lesion or 5 to 6 centimeter lesion, we can combine TACE with the microwave ablation. So what happens is that in Tata, what the practice was, transarterial chemoablation will be first we will do the microwave ablation followed by transarterial chemoablation. If it is if the margin, if it is high lesion, sometimes microwave transarterial chemoablation will be following microwave ablation, but that combination therapy is being used and it has a very good result as well. So artificial ascites also can be induced to separate the inseparable lesion to create an ablation. So what we'll create is that we'll create an artificial ascites, and we will do the ablation, so that the adjacent areas like bowel or the diaphragm will not be affected by the microwave ablation. As we can see in this cases, we have created an artificial ascites, and the lesion is being ablated. And other areas where we can see is that laparoscopically, minimally invasive surgery under direct vision. These cases has been seen. The laparoscopic ablation. The laparoscopic surgeon will be putting the antennae directly under the direct observation, direct vision. He will be able. The surgeon will be able to ablate the lesion under direct vision, and complete necrosis of the lesion is been achieved as it's seen in this case. And these are the other cases where the laparoscopic ablation has been done. Laparoscopic ablation and recheck was showing that complete ablation achieved for the treatment. And ablation can be done even during the surgery. Directly, we can put the antenna and we can ablate the lesion. And as we can see in this case, the lesion is completely been ablated. And directly we can see, and direct observation we can see, and we can see how effectively the ablation is being helping in lesion tumor. So with this, I would like to conclude that microablation got a very important role, and the follow-up scan after the microablation of a lesion should be 1 month. We should always have a criteria for this, and the coagulative necrosis is the main achievement of microablation. We will be using 60 watt or the ability, depending upon the ability zones and all. So combination therapy is also one of the important things which we can use for treating the liver lesions. Thank you.
Thank you, Dr. Sabrish. That was such an energetic and such an informative talk. And I always see your enthusiasm when it comes to teaching. And thank you so much from all the participants and too. Thank you.
Thank you, sir. Thank you so much. Thank you for the opportunity. Thank you.
Okay, so the next session will be by me. It will be so I'll be going to talk about transarterial chemoembolization. So after learning about hepatocellular carcinoma surveillance and BCLC classification, it makes my job very easy to discuss the transarterial chemoembolization. As we know, hepatocellular carcinoma has various treatment modalities, and transarterial therapy is one of them. The transarterial therapies can be of two types. It can be transarterial chemoembolization, or it can be just intraarterial chemotherapy. Now, if you go, so in every case of hepatocellular carcinoma, the first line of treatment should be surgery. It should be resection or it should be liver transplant. If the surgery is not feasible, then it is always our responsibility to convert the patient to be resectable. If that is not possible, then we go to all other modalities of treatment. So if the surgery is not feasible because of FLR issue, then we do portal vein embolization. But if it is because of large tumors present on both the lobes, or diffuse tumors, then we do transarterial therapies, that is transarterial chemoembolization. Now, the indications of transarterial therapy, the first and foremost, the lesion should be unresectable. And then if the tumor is resectable, but the surgery is not feasible, that is other indication for the transarterial chemoembolization. Now, when do we do ablation? Now, if the surgery is not feasible, and if the surgery is feasible, but patient is not a candidate for surgery, then ablation is the next modality of choice. And we do it mainly when the lesions are less than 3 centimeter, 3 lesions less than 3 centimeter, or a single lesion less than 5 centimeter. If not, then we do transarterial chemoembolization. And also the patient should be technically feasible. It should not be in any critical areas, but even in these areas nowadays, we can do embolization. Now, going on to the management of HCC, as we know that in intermediate stage, the TACE was one of the main treatment according to the older BCLC classification. Now, even in intermediate stage, if the transplant is possible, we should go for transplant. But in early stage and advanced stage, there was no role for TACE. It was always surgery or it was ablation. But if surgery and ablation were not feasible, then definitely TACE had a role. And very tiny HCCs had very good outcomes with conventional TACE as well. But the recommendation says in early stage, if ablation is not possible, if surgery is not possible, that is when we can do TACE. In case of advanced stage, now when we say advanced stage, whenever there is portal vein tumor thrombus, or if there is extrahepatic disease, then it comes to advanced stage. The portal vein tumor thrombus can be very small tumor thrombus in the segmental or subsegmental part of the portal vein. Such cases, again, we can offer TACE. It is much better than offering just systemic therapy. Now, indications for TACE other than hepatocellular carcinoma are: we can treat for intrahepatic cholangiocarcinoma when it is inoperable, or metastatic colorectal cancer, solitary metastasis in the liver, which is not responding well for chemotherapy, then ablation is one of the good choice. And neuroendocrine tumor, liver limited metastasis, then again, it is one of the important management that we can use. Now, what are the contraindications for TACE? One that we all know is a portal vein tumor thrombus. Again, portal vein tumor thrombus, it is not always a contraindication. It is contraindication when there is a main portal vein tumor thrombus. That is because even after doing TACE, the survival will not improve more than 4 to 5 months. Now, that is the reason portal vein tumor thrombus, specifically the main portal vein tumor thrombus, is a contraindication. Hepatic function, impaired hepatic function is a major contraindication, because in such cases, if you do TACE, then the liver dysfunction will continue and the patient will have liver failure. And as we saw in the BCLC grading, once the performance status become poorer, then the patient will not be possible to do TACE. And the more the performance status goes bad, the patient will go for just for a palliative therapy. Then any other contraindications for angiography will become a contraindication for TACE as well. Now, the relative contraindications includes the tips and segmental and subsegmental portal vein thrombosis. Now, physiology of transarterial therapy is that what we already know is that the theory says that when the tumor, any tumor in the body, when it is more than 1 square centimeter, it develops its own blood supply, and hepatocellular carcinoma develops blood supply from the hepatic artery, and predominantly by the hepatic artery. It might have very less supply from the portal vein, but the liver will have blood supply predominantly by portal vein and very less by hepatic artery. Now, this is where if we block the hepatic artery, the liver parenchyma may not damage, but hepatocellular carcinoma will be completely destroyed. It will undergo ischemic necrosis. And also, in case of so what is our goal when we do a transarterial chemoembolization? Is it completely curative? It may be, it may not be. But what is our aim in transarterial chemoembolization is the prolonging the survival, improve the quality of life, and decrease the systemic toxicity. The recommendation says that transarterial chemoembolization is not curative, but it can help to downstage the disease and help make the patient go for some curative therapy. Now, how do we select the patients? The clinical status becomes most important. Child's stage becomes most important, because as the child stage is bad, if the child sick case, we cannot take for the procedure because this will lead to liver decompensation. Also, if the bilirubin is more than 2, if the AST level is more than 100, if the LDH is more than 425, we cannot take the patient for TACE. So if the patient, any patient, we have to do TACE, bilirubin becomes very important. Bilirubin should be less than 2. Some even consider up to 3 to perform TACE. And presence of ascites or biliary dilatation is again becomes a contraindication for TACE. So some cases, even mild ascites will be considered for performing TACE. But gross ascites and biliary dilatation, these are the things that we have to look for before doing TACE. Now, after seeing the clinical status, now next most important thing is to look for the preserved portal blood flow. Now, as I told, the liver gets predominant blood flow from the portal vein. That is why we can block the hepatic artery. Now, if the portal vein is thrombosed, completely thrombosed, or if there is a hepatopetal flow, the blood is flowing away from the liver, then if we block the hepatic artery, the liver will be decompensated. There will be no blood flowing to the liver. Now, that is why the preserved portal blood flow becomes very important. And also tumor burden. Now, whenever we do TACE, it should have some survival benefit to the patient. We cannot treat a patient who is having extrahepatic disease, which will lead to increase in the extrahepatic disease even after treating the liver component of it. So it should be a liver only disease, and it should be less than 10 centimeter. And the venous invasion becomes very important to see, because the main portal vein having portal vein tumor thrombus, we cannot do TACE. We'll have to do some treatment like TARE. And we have already discussed how the child book scoring is done. Now let's go into type of TACE. Now, first one, what initially it was being done, and even now that we are doing, is a conventional TACE. Now here what we inject is a lipiodol, which is nothing but ethiodol, which is extract of a poppy seeds. Now this is acting as contrast agent, and it is acting as an embolizing agent. Now this is mixed with the drug that what we use regularly is doxorubicin. So lipiodol is emulsified with doxorubicin, and this is injected after selectively cannulating the hepatic artery. It is injected into the tumor. Now, most important to note is that whenever we inject a conventional TACE, the lipiodol emulsion, what emulsion we usually take is 3:1 concentration, 3 parts of lipiodol, 1 part of the drug, and we inject it. Now, this will go into the terminal feeding artery, and it will go into the tumor, and it will go beyond into the portal vein. Now, that becomes important now. So this is why very small tumor, conventional TACE, tiny tumors, conventional TACE can be curative, because it will completely cut off the blood supply of the tumor, and it will lead to necrosis. It's almost like an ablative treatment for it, and it will be almost curative. Now, important thing is to know what is the end point of the treatment. Now, 2 things we will have to see. One, the filling of the portal vein after filling the tumor. And the second thing is the tree-in-winter appearance of the terminal hepatic artery filled with the lipiodol. Now that becomes important. So this is the endpoint for a conventional TACE. And injection should be in incremental and continuous injection. And once the embolization is done, always the main trunk will be blocked by a PVA particle or gel foam, so that it will be completely cutting off the blood supply to the tumor. Now, once the lipiodol is injected, the lipiodol goes entirely into the tumor and the terminal feeding artery and just the portal vein. And there will be some lipiodol that will be gone outside into the normal liver, which will be cleared by the Kupffer cells in the liver. And at the end, only the lipiodol will be retained within the tumor. So this is how we will see the cutoff of the complete tumor after the injection of the lipiodol. Now, post-procedure angiogram reveals complete removal of the tumor. Now, this is how the follow-up imaging, once we do a follow-up imaging, if you just do a CT after a month, we will know that how much lipiodol is deposited within the tumor, how much the lipiodol, how much of the tumor is spared. Now, we will always expect to have a complete lipiodol retention, and homogeneous complete lipiodol or patchy complete lipiodol retention is the best to have a good tumor control. Now, that was a conventional TACE. Now, what we have developed is the drug-eluting microsphere TACE. Now, in this, we take the microspheres are prepared around 100 to 300 micron is what we usually use now, but there are 300 to 500 and 500 to 700 microns particles are also available. The beads are also available, but what usually preferred is 100 to 300 micron. Now, here again, doxorubicin is taken. Usually 50 mg of doxorubicin is taken in 2 ml of sterile water. We should not take it in the saline, because saline is ionic. This is because once we take the doxorubicin in sterile water, next we take the beads, DC beads, and mix the DC beads with this doxorubicin. 2 ml of doxorubicin is mixed with these DC beads. Now, the DC beads will have some sulfonate component on the surface, which will be having negatively charged in it, and doxorubicin will have positive charge in it. Now, because of that, doxorubicin will go and bind into these beads. Now, once the beads are injected into the blood, Now, in the ionic solution outside, these beads will slowly start releasing the doxorubicin. Now, that is the principle of the drug-eluting microsphere TACE. Now, once we inject this, now these particles will go into, after selectively accessing the hepatic artery, we inject the particles which go and sit in the capillaries, and it will release the doxorubicin for a long period of time. It can release up to 14 days. It will be releasing the doxorubicin into the tumor, and it will cause the damage to the tumor. So advantage is this will cause very high intratumoral doxorubicin level with very low systemic exposure, unlike systemic chemotherapy. So this is better tolerated, and very high dose of is given into the tumor. Whenever we give drug-eluting microsphere TACE, the maximum cumulative dose, the maximum dose that we can give per session is 150 milligram per session, and maximum cumulative dose is 450 milligram per meter square. So maximum cumulative dose means that when you're doing repeated sessions of TACEs, we should not cross the dose after multiple sessions. By adding all the sessions, should not cross more than 450 milligram per meter square. Now, endpoint in case of a drug-eluting microsphere TACE is that there should be stasis seen, and this we see after doing an angiogram. If you count for 10 cardiac beats, and if there is no clearance of the drug, then of the contrast, that means that there is that is a stasis, and that is the endpoint. This is how we have to selectively cannulate the feeding artery while doing these TACE, so that we embolize only the tumor and not the normal liver. Now, SACE score is a score that is given to decide the end point of a TACE, and they have various grading, but not that important. So one very important thing about this is the conventional TACE and drug-eluting microsphere TACE. The lot of studies, the recent studies like Precision trial and Precision Italia trial and meta-analysis by Facchioroso, all these things showed that there is the drug-eluting bead TACE or drug-eluting microsphere TACE is not superior over the conventional TACE. There is no significant difference in survival rates, and also if you notice the complications, there is no difference in the complications like post-embolization syndrome and increase in the liver enzyme, which is commonly seen any TACE, and it is always seen. But if you see conditions like biliary injuries, global hepatic damage, and hepatic arterial damage, arterioportal shunt formation, these are all higher in case of drug-eluting microsphere TACE, whereas only post-procedural pain was noted more in case of a conventional TACE. I just wanted to make a note of that. Now, one of the very important complication of this TACE is a post-embolization syndrome and transient increase in the liver enzyme. That's because the liver is getting damaged, the liver is getting damaged, necrotic. Now, this can be avoided by using degradable starch microsphere TACE. So this is something new that has come up in TACE. Now, degradable starch microsphere TACE is the starch is extracted from the potato, the hydrolyzed starch is extracted, and then this is used to make some particles, and the drug is loaded with this and injected. Now, what happens here is that when we inject these particles, it will take go to the tumor bed, it will release the doxorubicin, and this starch, DSM particles will be absorbed by the amylase action on it. Within 4 hours, the entire particles will be absorbed. So what happens? You are not blocking the hepatic artery, but the concentration of the drug is very high at the place where the tumor is, but we are not blocking the artery. So this is why this can be used in portal vein thrombosis case. This can also be used when the bilirubin is more than 3 milligram per deciliter. So when the bilirubin is high or when the portal vein thrombosis, TACE is not always contraindicated, because we have this newer technique of desorbable starch microsphere TACE. Now, next one more new technique, this is developed by Japanese, is that the balloon assisted TACE, in which the microcatheter is passed into the terminal artery, hepatic artery. The balloon is inflated. The balloon should be less than 4 mm to prevent any arterial damage. You block the vessel, and then we inject the lipiodol emulsion, and this will tightly pack the tumor and it will give us better result. Now, whenever we inflate this balloon, we see the pressure that is present within this hepatic artery. What we expect is a drop in the pressure, and if there is significant drop that is less than 62 millimeter of mercury, that means that there are no any collaterals that are present from the outside, or if they are present, they are very tiny collaterals. So in such cases, we can give very high pressure and inject, and it will go deep inside the tumor and it will cause very good ablation. Now, if the pressure is more than 62 mmHg, then we will have to give slightly lower pressure because there are some collateral. So this is one more newer technique, that is the balloon assisted TACE. So, and even if there are some when we give forceful injection, the more blood, more vessels that are feeding vessels to the tumor will be filled. So this is one of the examples of the balloon assisted TACE. We can see the balloon here, and this is how the result of the TACE looks. So as I told, complication post-embolization syndrome is very common complication. After that, it is liver enzyme elevation. The post-embolization syndrome, it will be something like flu-like syndrome. Patient will have fever, nausea, vomiting, and this will be there from 3 to 7 days. So in these 3 to 7 days, if this is present, then we don't have to worry. But if the fever persists for a long time, 2 weeks, 3 weeks, then we have to suspect some sort of infections. And there are other complications like abscess, cholecystitis, renal failure, edema, and even 1 to 3% cases, even the death is noted. Now, how do you follow up these cases? After a hepatocellular carcinoma TACE, after 4 weeks, a repeat CT or MRI, and then every 3 monthly, we have to repeat CT or MRI to look for any recurrence at the same site or any new lesions. There are some criteria to tell that there is tumor failure or tumor refractoriness. Now, it can be done in imaging. And as we discussed previously also, TACE can be combined with ablation, or it can be combined with radiotherapy or systemic therapy. The ablation, we can extend the zone of ablation up to 7 centimeters if you're doing an overlapping TACE, and can have good outcome. And that's about the TACE. I hope I have explained in detail, and thank you so much for your patience listening. Okay, I think next we have Dr. Jaspreet Singh, who will be talking about radiofrequency ablation. Over to you, Dr. Jaspreet.
Hello, am I audible?
Yes, Dr. Jaspreet, you're audible.
Okay, thank you, Pradeep, for giving me the opportunity to speak. And I'm Dr. Jaspreet. I'm consultant diagnostic and interventional radiologist at Indus International Hospital, Varanasi. So I will be talking about radiofrequency ablation in liver tumor. So there are different locoregional techniques to deal with inoperable liver tumors. So all aims at eliminating or reducing tumor viability, delaying progression. So overall prolonging the survival of the patients. So options include local ablative techniques and intra-arterial techniques. In intra-arterial, there are TACE, TARE, and in local ablative techniques, we have physical and chemical ablations. In physical, we have thermal, cold, and electric. In thermal, we have microwave ablations, laser ablation, and RFA. In cold, we have cryoablation, and in chemical, in electric, we have irreversible electroporation, and in chemical, we have ethanol injection. So what is the principle of RFA? It depends, the principle is Joule effect. So what is Joule effect? When an electric current from the generator oscillates between electrodes through ionic channels. It leads to frictional agitation and leading to production of heat, which causes the ablation of the tumor. So the goal of ablation is to induce coagulative tumor necrosis with temperature above 60 degrees. The thermal ablation is aimed at inducing a 10 mm margin ring around the tumor edge to remove small, undetected microsatellites. So the radiofrequency ablation equipment normally consists of RF energy generator, a probe, and a grounding pad. Here, RF probe act as a cathode and pad act as an anode, so that forming a complete electric circuit. So the reflux around the probe is high because the cross-sectional area around the probe is very small. So the energy reflux is very high in this area, leading to more heat in this area, not around the pad. So causing a lot of heat production and causing ablation of the tumor. So what are the different types of electrodes? So we have bipolar electrodes, which have both cathodes and anodes in the same probe. And we have monopolar electrodes, which are single electrode, adjustable electrodes, and expandable electrodes. In adjustable, we can adjust the field of ablation. And in expandable electrodes, we use to ablate the larger tumors. So this is the cooling electrode. Here there is a central tunnel, which is used where we use the chilled water to cool the tip down. So there are two modes of radiofrequency ablation. One is monopolar mode and other is bipolar. In monopolar, we involve the insertion of the electrode into the target tissue and the attachment of grounding pad to the back of the patient's thigh, so forming a complete circuit. Here, the energy dissipate from the travels from the cathode to anode. As you can see, so because of this reason, the energy is not static in this region. It is flowing towards the cathode anode. Sorry. So there's small ablation zone, and risk of tumor tract seeding is high because we are always puncturing the tumor. Although this is rare, but this can happen. In bipolar, it requires the insertion of both positive and negative electrodes into the target tissue, which negates the need of grounding pad. Electric current flows exclusively between the pairs of electrodes within the target tissue. Here you can see we have inserted into the target tissue, where we can see the energy is current is flowing in this area. So there is a large energy in this region, leading to making of larger ablation zone and more predictable coagulation zone. So bipolar mode of RFA are used in no-touch technique. So what is no-touch technique? In no-touch technique, we are not puncturing the tumor. We are placing the RFA probes adjacent to the tumor. So the aim is to ablate the tumor by overlapping the ablation zone of these three probes. So you can see that here we have achieved a good peritumoral margins. So in no-touch bipolar, multi-bipolar RFA, there is an active margin ablation is there, and reliable ablative volume and low heat sink effect as compared to monopolar RFA. So according to American Association for the Study of Liver Disease, European Association for the Study of the Liver, and Asian Pacific Association for the Study of the Liver have adopted RFA as the first primary therapy for single tumor less than 2 centimeters. So indication is we have Dr. Sabresh has described it very beautifully, that indications are very early and early stage according to BCLC classification, and less than 3 tumor and each less than 5 centimeter in diameter. Primary liver cancer or metastatic tumor like colon cancers or neuroendocrine cancers can be treated. And the tumor site should be more than 1 centimeter beneath the liver surface to prevent the complications like peri-hepatic hemorrhages and the burning of the superficial muscle and skin. And the tumors should be present more than 0.15 centimeter from the major hepatic vein and portal veins to prevent the heat sink effect. This is also used to downstage of the liver cancer in order to facilitate subsequent surgery or liver transplant. And we have to, we can be used RFA with combined with TACE. In RFA, we used to do TACE first to reduce the blood flow to the tumor, and then we'll ablate the the cancerous part of the tumor which have not taken the TACE, means lipidol. So we can specifically target that one. And after TACE, the heat sink effect will be very less because we have blocked the supply of the tumor. So this is at BCLC classification. In very early stage and early stage, there is ablation is the preferred treatment of the choice along with resection. So contraindication is when the patient with blood coagulation problems are there, and the relative contraindications are vital organs adjacent to the tumor like gallbladder, intestine, stomach, and heart. We can do in this kind of patients like hydrodissection techniques, we can do the ablations like Dr. Subresh has told us. We can induce artificial ascites in cases of gallbladder, intestine, and stomach. And if there is a subdiaphragmatic lesion is there, then we can produce artificial pleural effusion. So relative contraindication size is more than 5 centimeter because the curative intent more than 5 centimeter is less, but we can do it for the intent of cytoreduction. For the patient selection and preparation, we have to have basic biochemical tests, prothrombin time, CBC, and then liver cirrhosis classification according to childbirth class A, B, not in decompensated liver disease. And then platelet count should be more than 40,000, viral markers should be there. But in cases of ascites and pneumobilia, there are increased risk of infection and biliary-enteric anastomosis because sometimes what happens is the intestinal flora has come up into the ablative zone, and there is a high chances of abscess post ablation. So there are 3 approaches: percutaneously, laparoscopically, and open surgery. In percutaneous, all have their advantage and disadvantage. So in percutaneous, it is the least invasive and effective in tumor less than 3 centimeter. Multiple ablations can be done in a single sitting. It can be done in OPD basis also. And in disadvantage is poor visualization of small surface and deep lesions, high recurrence for the larger and the lesion adjacent to the vessels. In laparoscopically, allow manipulation of the adjacent structure, and deeper lesions can be assessed easily. In laparoscopy ultrasound, we can detect lesions less than 1 centimeter and ablate them. But the disadvantage is it requires multiple small incisions on the abdomen. And in open surgery, it is the best for ablation of the larger tumor, direct control of hepatic perfusion. So when we control the hepatic perfusion, the tumors adjacent to the large vessels can be best approached by the open surgery. So there is a maneuver called Pringle maneuver. In this one, we clamp the portal vein and ablate the lesion. So by this lesion, we are decreasing the heat sink effect because vessels are occluding. Best when tumor located near the vessels and allow manipulation of adjacent structure. So open surgery is most invasive and surgical complications also arise after this surgery. So there is a video which I have recorded during my fellowship period. So this is the case of oligometastasis to the liver from the colon. There was a large mass in the left lobe of liver which was resected by the tumor. So this was a microwave actually. So we have done intraoperative ablation of the 2 metastases, which was located one in the caudate lobe and one in the posteriorly hepatic segment 7 of liver. So you can see surgeon has rotated the liver anteriorly so that we can easily assess the lesion. So this is the microwave probe. We are inserting it under the guidance, and you can see there are large portal. RF is not used because of the large vessels around it. So this is how it looks like when there is ablation. Now there a lot of air has come up in this area. So we can also see the air is going into the vessels also. This is non-significant. You don't need to worry about any air embolism or something like that. So this is how when the tumor is ablating looks like. So this is going on same thing. So every probe repositioning and the final removal of the probe after RF fail must be performed with hot withdrawal or track ablation with 70 to 90 degrees Celsius for 1 minute approximately in order to prevent local hemorrhage and neoplastic seeding. So complication during procedure can occur. So these includes intraperitoneal bleeding, portal vein thrombosis, bile duct injuries like stenosis and leak, pneumothorax, pneumoperitoneum, liver failure, liver abscess, a tumor seeding, and post-ablation syndrome. So when to do an imaging? So we have to do immediately post-ablation imaging also, and then after 1 month, then third, and then 6 months. So what we have to see on imaging? So first we have to see the ablation zone. Immediately after RFA, ablation zone should be larger than the initial tumor, which tells us that we have completely ablated the tumor. And immediately after procedure, it looks like hyperdense in CT because of some coagulative necrosis and hemorrhage within the tumor. And ablation zone can be spherical or oval or oblong, depending upon the type of probe and number we have used for to ablate the tumor. And tiny bubbles immediately after RFA is not to be mistaken for the abscess because air can occur after the RFA ablation. So this is the tumor. We can see this is a contrast CT. There is heterogeneously enhancing hepatic tumor, peripheral hepatic tumor. The PET scan shows avidity, and immediately post contrast. Immediately after ablation, we have done CT, which showed central hyperdense, and it is larger than the previous tumor. This is non-contrast. You can see hyperdense slightly. And this is the scan done after 2 months. We can see there is no hyperdensity now. It has completely resolved, hemorrhage has resolved, and it is also shrinking in size. So this is the case where abscess has formed. Abscess usually occur after first week of the ablation, and patient presented to you with a fever, leukocytosis, and pain abdomen. So you have to drain the abscess by pigtailing, and after pigtailing, there might be some scarring, like in this case, on the retraction of the liver capsule can be seen. So periablative changes. In periablative changes, we have to see the periablative edema and periablation hyperemia. This we can see immediately after RFA. So there is a on T2FS images, we can see thin rim of hyperintense rim, which tells us the periablation edema. And on post-contrast images, we can see there is a peripheral enhancing area, which is periablation hyperemia, which is due to inflammatory reaction and granulation tissue formation induced from the thermal injury. It should not be mistaken for the tumor, residual tumor, unless until it's a very nodular or heterogeneous enhancement. So this is the case of tumor recurrence. So after ablation, we have seen the patient has come for after 6 months, and we have seen there is a peripheral small tumor recurrence and same showing activity on the scans. So biliary changes. In biliary changes, we have transient and persistent biliary changes. In transient, there is a duct dilatations along the peripheral zone of ablation, which resolves as the ablation zone decreases in size and as associated inflammation resolves. Here you can see there is a transient biliary dilatation, and it might be persistent when there is a permanent damage to the tumor. So you also can get hemorrhage in the gallbladder when we do the ablation adjacent to the gallbladder. So there is a bilioma formation when there is a significant biliary damage and there is a cavity formation around the ablative zone. So you can also get a bilioma formation. So this also has to be drained if they got infected. Otherwise, if they are increasing in size, then we have to intervene. Otherwise, we have to leave it. So vascular changes. So in vascular changes, we can see a perfusion abnormality in the form of a peripheral wedge-shaped area of enhancement adjacent to the ablative tumor. You can see adjacent peripheral wedge-shaped enhancement. This is perfusion abnormality. Why this happened? This happened because of the mechanical trauma or thermal injury to the portal vein branch. And there is a compensatory perfusion from the hepatic artery or formation of peripheral arterioportal shunts. It should not be mistaken for the tumoral enhancement. So hepatic infarction can also occur when there is a central tumor. It can thrombosed or got central veins, the arteries can be thrombosed or injured, can lead to hepatic infarction. So, and in the central part also, you can also get pseudoaneurysm due to arterial injuries. So other perihepatic changes are hematoma, ascites, tumor seeding, tumoral tract seeding, and pneumoperitoneum and hemothorax. So I think this Dr. Subresh has covered well, and most of the things are same. In RFA, we have grounding pads. In microwave, we don't have grounding pads. In RFA, there is a high alternating current. In microwave, we have microwave radiations that are independent of tissue impedance and does not respect boundaries. That's why the heat sink effect is not there in microwave as compared to RFA, which depends upon the tissue impedance and the water content. And the low temperature, intratumoral temperatures are low in RFA, and microwave is high. And multiple lesions can be treated simultaneously by microwave because the intratumoral temperature is high and shorter procedure time. The surgical, one more important point is surgical flips and pacemakers are contraindicated for RFA as alternating currents are there. And in microwave, surgical flips and pacemakers are not contraindicated. Thank you.
Thank you, Jasprit. That was very good cases and different ways of doing RFA. Thank you so much for the presentation. Now we have Dr. Saurabh Rai, who will be talking about portal vein embolization. Over to you, Dr. Saurabh.
Am I audible?
Yes, you are audible.
Hello?
Yes, you are audible.
Okay, let's start with. So I'll be talking on portal vein embolization. So portal vein embolization is a technique to selectively occlude blood supply to the liver lobes.
I'm not able to see your screen. Can you share your screen?
Yeah, just a second. Okay. Is it visible now?
No, we can see your WhatsApp.
Just a second. Okay. Now?
Yes, now we can see. We can max.
So
can you make it big? Can you expand it?
Right, sure. Just a second. Is it okay now?
Yeah, perfect.
Okay. So portal vein embolization is a technique to selectively occlude the blood supply to the one of the liver lobe, especially which containing tumor burden. So diverting the blood flow to the other lobe and causes hypertrophy of other lobe, which is a future liver remnant. And the purpose of this embolization to divert the flow and increase the flow towards the future remnant segment of liver, and so improve the surgical outcome by preventing the liver insufficiency. So the minimal limit for the future liver remnant should be 20 to 40% depending upon the liver function status. So why portal vein embolization? If there is a tumor, usually the liver transplantation is a treatment of choice, but liver transplantation is limited by donor shortage, strict transplant criteria. Hence, the liver section is the mainstay of curative therapy, and the improved surgical technique and liver unique ability to regenerate allow for the resection for the most of the liver if necessary. What is future liver remnant? It is the percentage of liver that remains after the surgery, and it is a strong and independent predictor of both surgical hepatic dysfunction and complication. Before this embolization, we take a triple phase CT angio to calculate the FLR as well as to visualize the anatomy and if any variant in the portal vein anatomy. If there is a larger patient, it requires larger liver mass to support the essential function. However, in smaller patient, require a smaller FLR. FLR must be standardized relative to the patient size as a ratio of FLR and total functional liver. However, the SFLR, that is standardized FLR, express the percentage of total functioning liver. So in this picture, we can see there is a green light color stain which shows the future liver remnant, and this light orangish color shows the liver to be resected, and this is a total liver mass. total liver volume. However, when we calculate SFLR, we have to reduce this volume of the tumor because this is a non-functional mass of the liver. So we can see this is a 3D reformation image, which can see there is a total liver volume. If we reduce this tumor volume, it becomes the total standard liver volume, and we can calculate SFLR. Patient selection. Before the patient selection, we should know the functional status of liver. So we perform endocyanin clearance test, in which we inject tricarbocyanin dye, which binds with albumin, and it clears exclusively by biliary system. Hence, it is calculated either by blood test or by optimal sensor placed on finger. This value is described as a percentage of ICG that remains in the blood after 15 minutes. And if it is a ICG 15, which is also known as ICG R15 value, which indicates decreased hepatic reserve and need for the increased FLR. So if not, in case of normal liver function, FLR as low as 10% can support the essential function. However, post-operative complication and length of stay are significantly reduced if SFLR is more than 20%. Therefore, normal liver and portal vein embolization is advocated if the FLR is less than 20%. If it is more than 20%, the patient can tolerate, so no need of portal vein embolization. Same as in case of hepatic stenosis, or if patient is going to be on hepatotoxic chemotherapy, the portal vein embolization performed when the SFLR is less than 30%. In selective, usually the child B and C is contraindicated for the portal vein embolization. However, the selected case of child who A cirrhosis with preserved liver function, that is ICG R15 is less than 10%, are considered for resection if the SFLR considered for portal vein embolization if SFLR is less than 40%. So what are the contraindication? First, the ipsilateral portal tumor thrombus and the portal or the petrol vein thrombosis. If it is a portal vein thrombosis, complete portal vein thrombosis, it already done the job. It already diverted the blood flow to the contralateral lobe. Or if it is a partial thrombus, it may create issue while manipulating the catheter, and the delivery of embolic agent may be difficult. In case of portal hypertension, because we are embolizing the portal vein, so it may lead to the increase in, it may exacerbate the portal hypertension. Relative contraindication is extrahepatic mets, tumor in the expected FLR, tumor blocking safe access to portal system, biliary dilatation, mild portal hypertension, and coagulopathy and renal insufficiency. Technical consideration is our goal is to achieve complete portal vein occlusion from the entire portal tree. Otherwise, if distal part is left, it may lead to portal shunt. Embolic agent usually most commonly used N-butyl cyanoacrylate and the coil with the particle. However, the ethanol and fibrin glue also can be used. So right versus left. In case of left, extended left hepatectomy, which involves the left lobe as well as 8th and 5th segment. After the resection, there is a 7 and a 6th segment 7 and segment 6 is left. So it accounts for more than 33% of FLR. So usually in case of extended left hepatectomy, usually the portal embolization is not required if the functional status is okay. However, in when surgeon plans for extended right hepatectomy, usually less than 20% of volume left, so the portal vein embolization is important. So percutaneous approach, ipsilateral versus contralateral. Ipsilateral approach is the ipsilateral side which contains maximum burden of tumor. So in this we can see there is a tumor burden mainly on right side. So right anterior portal branch is punctured. Here we can see there is a contralateral approach where tumor burden on the right side. However, the access was taken from the left side and reached up to the right portal branch. We'll explain the procedure. This is a image which shows there is an ultrasound guided puncture of right anterior segment of portal vein. Usually 22 or 21 gauge or NEF set is used for the puncture under the local anesthesia. This is we see after the needle access, we give a contrast and confirm the portal vein branch. We can see there is a contrast is running towards periphery, which suggests portal vein rather than the biliary system. Now, after the needle is confirmed and in the position, now the micro wire is or the puncture set wire is passed to toward the central branch or toward the main trunk of the portal vein. This is the after the access after the one sheet is secured, usually 6 French or 5 French vascular sheet is secured. A pictal catheter is passed in a main portal vein, and this portal venogram is performed, which shows there is a right as well as a left portal branch. This is the embolization of first. This is an angioportogram after the first branch embolization. We can see there is a coil embolization is done. Before the coil embolization, there is a particle embolization was also done. This is a photogram after the first branch as well as embolization of second branch. The only branch is left is through which we went inside. So this is a photogram before the embolization, and this is the photogram after the embolization. We can see there is a coil in the target portal veins, and there is a opacification of the non-embolized left portal vein. This is a pre-embolization late phase, where we can see there is a no staining of right portal vein as well as no staining of liver parenchyma. Same in the parenchymal phase. Okay, we can clearly see no opacification of FLR and non-opacification of the embolized segment. Now, after performing the procedure, while coming out, as we know, there is a high risk of bleeding. So, tract embolization is done, usually done by the coil. It can be done by microcatheter as well as by main catheter with O35 coils. If the procedure is performed with glue, so tract embolization is also can be done while coming out. The glue is injected with the main catheter, and tract embolization can be done. See another case, we can see there is a before resection you can see there is a very small future liver eminent on left side. So this is second image where photogram is performed. We can see there is a SS side catheter. Now a reverse catheter is used mostly. We use a reverse curve catheter, but KMP and other catheter can be also used depending upon the operator. Sorry. So here we can see there is a selective photogram of the target vein. Now this is a post embolization photogram. We can see there is a coils and there is a non-opacification of embolized segment. This is the follow-up scan after the embolization, where we can see there is a coil in right portal vein branches, and we can see there is a staining or retention of contrast in portal venous phase due to portal vein embolization. However, the FLR in FLR segment we can see there is a no staining, and this is after the hepatic resection, right hepatectomy. We can see there is a liver segment, residual liver segment or FLR, hypertrophied FLR. Again, we can see here another example where we can see there is a small FLR before the section, while the after the embolization we can see there is a increased size of the FLR, and this is after the resection residual liver segment. This is another example of portal vein embolization here where the glue is used with lepidol, and the embolization was done. In fourth image, you can see there is an implantar vascular plug. Sometime if there is after the portal vein embolization, if there is a no significant hypertrophy of liver parenchyma noted, then one can do portal vein, hepatic vein embolization of ipsilateral side. So here there is a two hepatic vein embolization was done with the vascular plug. So hypertrophy is used. Some studies shows there is a more hypertrophy if the portal vein embolization or hepatic vein embolization done together. However, usually portal embolization is done first. If there is no significant hypertrophy, then hepatic vein embolization can be done. So what are the tips and tricks? Not all liver are created equal, so there is a significant variation in segmental and portal venous anatomy. So we should assess before while with the CT about the portal venous anatomy. The volumetric cutoff needs to be adjusted depending upon the underlying baseline liver function. And portal vein embolization is an adjunctive to the technique. It is an adjunctive technique to the surgery. So the contraindication to the surgery is always contraindication for portal vein embolization. Because of two-stage hepatectomy has increased in the number by surgically resectable conditions, such that expanding the number of patients with eligible for portal vein embolization. Liver volume must be normalized according to the patient size. A larger patient requires a larger FLR. If there is a ipsilateral approach, usually ipsilateral approach is performed to avoid the FLR injury, allow the easy access to the segment 4. If we approach from the right side, we can easily assess after the reaching up to near the confluence, we can easily enter to the left side and easily assess the portal segment 4. So if we start embolization from the right side, we should embolize the segment 4 first, because if we embolize right side and go for embolization for left side and there is an inadvertent embolization of left side, it could be the catastrophic. It may be patient develop fulminant acute hepatic failure. The embolic agent is the of choice. There is no such study to show which embolic agent have better efficacy, so it's operator choice. In case of right portal vein embolization and plus segment 4 embolization, result is more, sorry, it is a bit result is better than the only right portal vein embolization. So usually it should be performed with around with segment 4. The transarterial chemoembolotherapy can be done in the staged fashion before total embolization to prevent the tumor progression and boost the regenerative stimulation of the chronically diseased liver. So it can be done, transarterial embolotherapy can be done, but it is not required in every case. Thank you.
Thank you so much, Dr. Saurabh Rai. That was too good presentation with such details on the embolization. Thank you. Thank you so much. So next up, we have Dr. Shankesh, who will be speaking about the liver transplant interventions. So he's from Rela, which is known for the liver transplants, and he's eagerly waiting to enlighten us with his post-liver transplant interventions. Over to you, Dr. Sankesh. Okay, I think I'll have to unmute.
Yeah, now am I audible enough?
Yeah, you're audible enough. Yes.
Okay.
Can you share your screen?
Yes, I'm doing it. Is it visualized?
Yeah.
Okay, sure. A very good afternoon, everybody. I'm Dr. Sankesh Mehta, and my talk for the day is on post-liver transplant interventions. Before commencing my talk, I would like to thank Dr. Prajwit and the organizers for giving me this opportunity. And I would like to thank my clinical lead and head of the department at Rela Institute, Dr. Deepashri, for guiding me throughout the 2 years of my IR trainee program and for guiding and providing the cases discussed today. Liver transplantation is used to treat both adult and pediatric patients with end-stage liver diseases. Today, it has become very prevalent as both surgical technique and post-op care have improved. But despite this, there remain serious complications of the procedure. This is where interventional radiologists come into play as a part of the multidisciplinary transplant team, because we have the advantage of a minimally invasive approach and we reduce the need for further surgeries and reduce morbidity. Before proceeding to the details, I would like to give a little data on the liver transplant which have been happening in Rela since its inception in 2018. Total number of liver transplantations which have happened until now are 1,095. out of which living donor transplants are 1,060 and deceased donors are 35. Adult and pediatric ratio is 744 is to 351, and male to female is 803 is to 292. Post-transplant complications can be broadly classified into three major categories: biliary, vascular, and parenchymal. I will proceed into the details of each further. Before proceeding to the complications, it is very important for us to know the four types of anastomosis which happen during the transplant. So here we see the caval anastomosis. Then here is the biliary ductal anastomosis, which can be of two types, which are the choledochal anastomosis or the choledocho-jejunal anastomosis, which we call the hepatico-jejunostomy. And the hepatic arterial anastomosis is the third one. Then lastly, we have the main portal vein anastomosis. Here we see the superior mesenteric vein and the splenic vein. Why am I talking about the anastomosis so much? Because the frequency of complications is much more at the anastomotic site than at the non-anastomotic site. As we see the incidences here, biliary anastomotic complications encompass about 25% of all, and the vascular complications, including the hepatic arterial, portal venous, and systemic venous, encompass about 9 to 12%. Moving on to the biliary complications, these include biliary leaks, which occur in the early postoperative period within 4 weeks. After that, we encounter the biliary strictures, which can, both of these can be anastomotic or non-anastomotic. If left untreated, these can progress to biliary stones, biliary sludge, or biliary cast syndromes. We'll come to each one in detail. So as I had said, there are two types of anastomosis, basically the choledochal anastomosis. This is of the anatomic type, and it is the preferred one also because post surgery we can have a retrograde access through ERCP approach. And the second one is the choledocho-jejunal anastomosis, which is the hepatico-jejunostomy. In cases of difficult CDCD anastomosis, we take this one also in cases of biliary atresia and sclerosing cholangitis. Anastomotic strictures. As I had said, these occur relatively later, which is after 4 weeks of the transplant. Within the first 3 months, they represent edema and inflammation. After 3 months, they generally represent fibrotic strictures, which are difficult to dilate. PTBD with plasty and internal external drain is the mainstay of management. Metallic stent should rarely be used as they preclude surgical revision and should be saved only for further non-surgical candidates. Moving on to the first case, these will be one of the commonest cases which we encounter as a post-transplant biliary complication. Here we see a 60-year-old gentleman who had undergone LDLT due to NASH-related cirrhosis, came about 8 months later, a week back, with the recent onset pruritus and deranged LFTs. MRCP was done and showed non-visualization beyond the hepatico-jejunostomy and proximal dilatation of the biliary tree. Representative cholangiographic image through right-sided percutaneous transhepatic biliary approach shows us there is a anastomotic stricture at the hepatico-jejunostomy site. So a simple 840 balloon plasty was done. We are able to see presence of wasting, which was completely treated on the plasty. Following this, we kept an internal external drain and we have called the patient for review in 3 months. So plasty followed by internal external drain and repeat cholangiogram and repeat plasty at 6 to 12 weeks interval has about 73% success rate at 2 years and 66% success rate at 6 years. If untreated or if presenting even later, these can progress to the next case, which I'm going to present, of a 10-year-old male child with biliary atresia, failed Kasai, underwent LDLT, was on irregular follow-up and drug non-compliance, had come a year after the transplant with an episode of cholangitis. MRCP was done and showed signal voids at the region of the hepatico-jejunostomy, which on representative cholangiographic image shows irregular filling defects. So this was again treated by a simple balloon plasty, following which we can see beautiful delineation of the contrast flowing across the anastomotic site. So these are about hepatic organostomies. In CD/CD anastomosis, generally they have a retrograde endoscopic approach. But what our role comes into play is sometimes in failed ERCPs, if they are not able to approach, like in this case, a 33-year-old male with cryptogenic CLD post LDLT had come 6 months later recently with weakness and abdominal pain and deranged LFTs. ERCP was done, as we said, it was not able to, they were not able to cannulate the right posterior segmental duct. Here we are seeing a non-visualization of the beyond the choledochal anastomosis. So we took a percutaneous transhepatic biliary approach and we are seeing narrowing at the anastomotic site. So in these cases, what we can do is we can pass the wire beyond the anastomosis into the duodenum, from where the gastroenterologists can take over like they did over here, and they railroaded a plastic stent through it and deployed it for further management of the stricture. To add a note, these are cutting balloons. As I had said, after 3 months of the procedure, most of the strictures which are persistent and say adamant strictures, even not healing by plasty, can be due to fibrotic strictures where these balloons have micro blades at the edges. So when plasty is done with these balloons, the fibrosis can reduce and the lumen can be restored. Non-anastomotic strictures, these generally occur secondary to hepatic arterial thrombosis or ischemia. Only symptomatic patients need to be treated with balloon dilatation. Stents can be relatively safely put in this group because these do not involve the anastomotic site. Again, these can proceed to biliary stones and casts. Coming to the most common early post-operative biliary complication, which are bile leaks. I think after graft dysfunction related liver biopsies, these are the commonest procedures which we have to do in the early post-operative period. These occur again at the site of the anastomosis due to decreased periductal tissue and increased tension. Management is done by two basic principles. One is to drain the biloma, and eventually the leaks will heal by themselves. If that doesn't happen, the second option is to divert the bile flow. As I said, 80% will heal without surgical revisions. So there are multiple methods in which we can drain the bilomas. Here we have used the CT guidance because of the presence of air in the anterior aspect of the collection and lung posteriorly. We have inserted a wide bore Malacot drain. Again, at the cut surface collection, if we have a good access, we can directly percutaneously ultrasound guidance. We can introduce a pigtail catheter. Sometimes if the access is jailed by bowel loop or the surface of the liver, we can use hydrodissection, or just a peripheral transhepatic approach also can be used to drain the collections. Here we see a case of a 53-year-old male who had come 4 weeks after transplant with the fever. There was a collection at the cut surface, large collection, which was drained by pigtail insertion. However, on day 1, day 2, day 3, large volume drain bile was draining, which was not reducing. So we had chosen the second option, which was to divert the bile flow. We took a percutaneous transhepatic approach, and cholangiography shows leak into the collection. So again, we crossed the anastomosis and we introduced an internal external drain to divert the flow, and patient is doing fine now. There is no significant biloma collection after. Moving on to the vascular complications. These can be of two types: inflow complications, which involve the hepatic artery and the portal vein, and outflow complications, which involve the hepatic vein and caval obstruction. Causes are numerous, which can include graft number, abnormal donor anatomy, conduit use, multiple anastomosis, intimal hypoplasia, torsion, and technical. Hepatic arterial complications such as thrombosis and stenosis and pseudoaneurysm exist, with the incidence as described here. Thrombosis occurs 42% in children and only 4 to 12% in adults. And thrombosis occurs relatively earlier in the post-operative period, whereas stenosis occur around after 3 months on an average. So as Dr. Priyanka had described about the normal hepatic arterial Doppler, I would not want to go into details of the three things which we need to keep in mind are resistive index should be between 0.5 to 0.8. acceleration time less than 80, and PSV should be less than 200. Here we see a typical post-stenotic waveform, which is showing a Parvus Tardis waveform, which is the acceleration time is much higher. There is no steep peak to the PSV, as we can see here, and also the PSV is reduced. So this is a typical Parvus Tardis waveform. Further, if Ri is less than 0.5, it is an ominous finding with 100% sensitivity to vascular complication. However, if it is more than 0.8, it can be resultant due to reperfusion edema or cold ischemias, and these generally resolve within 7 to 15 days. Transcatheter hepatic arterial thrombolysis and low pressure plasties have been tried in these patients. However, it should also be decided based on whether further surgery will be warranted, because these carry a risk of intra-abdominal hemorrhage and frequently require surgical revisions. Moving on to a case of a 5-year-old male diagnosed with arginine deficiency, for which LDLT was done 1 week, following which presented with deranged LFTs, and Doppler showed no significant recordable intrahepatic arterial flow. We can see here CCT abdomen and the arterial face showing non-opacification beyond the proximal hepatic artery. STEM catheter was used, and slowly with the microcatheter we tried to negotiate our way beyond the obstruction with gentle balloon maceration, low pressure plasty. And as you can see, eventually we are able to progress further, and mild distal recanalization of the vessels is seen. We left this on thrombolysis alteplase for 24 hours, following which a repeat angiogram was done, which showed beautiful distal recanalization of the vessels. Coming to the next complication, which is the hepatic artery stenosis. As I said, these occur generally 3 months post liver transplantation. Commonest location is again the anastomotic sites. These can be secondary to hepatic arterial thrombosis and can cause biliary complications also if untreated. Angioplasty should be attempted. If unsuccessful, can safely proceed to stent placement when compared to hepatic arterial thrombosis. Another thing, when we are doing plasty or any procedure in hepatic artery thrombosis, we should always have a stent graft ready, because anytime the vessel can rupture, and at that time we need to have things in hand. Technical success of hepatic arterial stenosis plasty and stenting is 80 to 90%, and physiological improvement occurs in 40 to 60% of cases. Here we see 2 cases of hepatic arterial stenosis. One is very tortuous, one appears relatively okay. This was treated with simple plasty with good distal recanalization. The tortuous hepatic artery here had to be stented because simple plasty would not have helped this. Moving on to portal venous complications. Portal vein thrombosis and stenosis encompass less than 1% of the complications. These occur due to vessel misalignment, differences in the caliber of anastomosed vessels, or stretching at the anastomotic site. If within 1 month, these are presented with hepatic dysfunction or failure. If these occur later, they usually presented with a sequelae of portal hypertension. So a 53-year-old male with NASH-related cirrhosis had undergone LDLT, came a month later with abdominal pain and bloating. Doppler had revealed ascites and significantly dilated portal vein with intraluminal altered echogenicities, showing no Doppler waveform. Just distal to this, we can see aliasing and distal normal waveform and color flow. CCT abdomen was done and confirmed a main portal vein intraluminal thrombus. So a decision was made to do a thrombectomy and a thrombolysis. Portogram showing irregular filling defects in the region of the main portal vein, and even along the SMV gram, we can see there is no significant filling along the main portal vein. What we had done for this was mechanical suction thrombectomy was attempted. If we can see here, there is a separator which is for clot lysis. So this is the device which we used, penumbra engine for suction. This is the suction catheter and the separator for clot lysis. Along with that, we did balloon maceration, and We aspirated multiple large clots. Following with progressive portogram showed a relatively good flow across the main portal vein. We had kept this patient again on thrombolysis for 24 hours and did a portogram the next day, which is showing beautiful recanalization of the main portal vein and the intrahepatic branches. Next case is of a chronic situation where a 5-year-old male with situs inversus totalis had come 5 years after LDLT, presenting with melena and hematemesis and altered LFT. CT abdomen was done, as we can see here, features of portal hypertension, multiple portosystemic collaterals, enlarged spleen, splenomegaly. But the main finding here is portal vein is not opacified at the region of the portal hilum. So there is complete cutoff with a short intrahepatic portal venous course. With this picture, we had understood that even if we try to go through the portal vein intrahepatically percutaneous approach, we might not be able to cross the obstruction. So we had kept a backup of a splenic vein puncture in our mind, which is what was done through the intrahepatic portal venous approach. We were not able to cross the obstruction. So we punctured the splenic vein with a 22 gauge Shiba needle and went across photogram, which we can see here. We can see the gastric varices and complete occlusion of the main portal vein at the hilum. With a Terumo wire, we were able to cross the obstruction, and a gentle plasty was done with 40 balloon, which resolved the gradient. Pre-procedure was as high as 16. Post-procedure, the gradient, post-plasty, the gradient had reduced to 7, and we had put a self-expanding metallic stent of 840, which showed gradient reducing to 3. Presenting good recordable flow is seen. And on our way out, we embolized the gastric varices with an 8 mm coil and the splenic puncture site with a 6 mm coil and glue combination. No hemoperitoneum was recorded after the procedure. On POD1, we are seeing good intrastent and distal to the stent portal flow. POD3, again, Doppler showing good portal venous flow. Patient was discharged the next day with a short dual antiplatelet course for 3 months. On POD15, again, we are seeing that the synthetic liver functions were fine and the portal flow is good. Coming to systemic venous complications, these generally present 12 months after the transplants. They are called as hepatic venous outflow obstructions. Occur incidence about 2% to 16%, more common in LDLT type of transplant than DDLTs. Locations include IVC, hepatic venous, and combined. Suprahepatic IVC present with features of Budd-Chiari and ascites. Infrahepatic IVC present with features of lower limb edema. So we had a 6-year-old male who had undergone transplant, presented a year later with the abdominal distension. Doppler was done and shows just suprahepatic IVC showing aliasing artifact. The CT had shown features of Budd-Chiari syndrome. IVC gram was done and showed a stenotic segment here, which was plastied with a 1660 balloon, and it was a web. So instantly post plasty, it showed reduction of gradient from 8 to about 2. Moving on to the parenchymal complications, I would not like to go to much details of this because this is one of the commonest procedures which we do, a non-targeted liver biopsy in patients within the first month post-transplant whose LFTs rise. And one thing we need to keep in mind is we should be as peripheral as possible and avoid the central structures. And in our institute, we always embolize the tract with the gel foam slurry. The next complication is recurrent HCC. So there are Milan criteria and UCSF criteria are the criteria under which liver transplant is done for patients with HCC, and reported recurrence rate is less than 10%. However, at our institute, we have seen at least 4 to 5 cases of recurrences, which there are ongoing studies to predict the factors. Early results have shown that the 3 main factors predicting these are tumor morphology, diameter number, micro and macrovascular invasion, and increased neutrophil to lymphocyte ratio more than 5 times the norm. A case of 64-year-old male diagnosed with NASH, CLD, and HCC and no macrovascular invasion. LDLT was done in 2017. On regular follow-up years later, we are seeing in the right lobe liver graph, heterogeneously enhancing lesion, AFP and PIVCA were elevated. Main component here is, as I had mentioned, the tumor morphology showing steatosis within the tumor. So transarterial chemoembolization was done in the similar way as Dr. Prajvit had beautifully explained, and patient is here to come for 1 month follow-up after. I would like to finish my talk with a very interesting case of a dual graft liver transplant, which was done on a 57-year-old female who was diagnosed with HCV-related cirrhosis in 2019 and had worsening of LFTs after taking homeopathy medicine. So why and how was this dual graft liver transplant planned? Her donor liver was given by her son. However, the percentage of the liver which could be transplanted was less than 27% of the required volume. So to support this left lobe graft of her donor son, a right lobe graft from a deceased pediatric child had been taken. This child had a propionic acidemia metabolic disorder. However, the liver was deemed to be well at least for a decade. So the right lobe graft was just to support the growth of the left lobe graft further. Post-transplant period was immediate post-transplant period was uneventful. Follow-up CECT was done in 2 months' time, which showed good opacification of the right lobe parenchyma. However, the left lobe parenchyma showing some mottle type of appearance, and there is relative distal pruning of the portal vein branches, not as well opacified as in the right lobe graft. So this patient was planned for a right portal vein embolization. As we can see, they have put a conduit also in the right main portal vein. Still, the majority of the portal vein supply is going to the right lobe graft. So we had done right portal vein embolization in this patient using coils and PVA particles. Following the embolization, we are seeing good distal portal venous branches present on the left side and good parenchymal blotch. After a month, PCD was repeated in this patient, which shows significant relative improvement in the size of the left lobe with the relatively better parenchymal enhancement. So just to sum up, this is a timeline of the occurrence of complication that I had mentioned, thrombosis in the arteries and portal vein being earlier within 4 weeks, anastomotic and non-anastomotic biliary strictures being about 1 to 6 months. And lastly, the portal vein stenosis, recurrent HCC and hepatic vein stenosis presenting after 12 months. The overall success rate of a liver transplant is strongly correlated with the availability of IR expertise. Transplant patients do not have the same immune and healing responses. Therefore, they are not very good surgical candidates. Thus, an IR team is required for aggressive percutaneous approaches for these patients. These are my references, and this is the team I had an honor to work with during my term in RELA. Thank you.
Thank you, Sankesh. That was such a beautiful talk. You covered almost all the aspects of post-liver transplant interventions. That was
Thank you.
good hearing you. Thank you so much.
Thank you.
Okay, so I thank all the speakers for being part of this Endovascular Intervention Radiology Academy and being and contributing so much. And I thank all the speakers for patiently listening to us and still listening for such a long time, even though we exceeded the time by 1.5 hours. So we hope we'll correct it next time. I think we should stick to our timings and then make it better. So I think now we can have one photo session with all of us together. And special thanks to Dr. Who has completed her MBBS from Ramaya Medical College, and she's helping us coordinate it purely on voluntary basis and tolerating all of us exceeding the time, and she has been keeping the track of it. So I would like to extend my gratitude to Dr. Priya for helping me out throughout, and all the members for being part of this event and making it a successful event and I have recorded the session, so I can share, like, then we can all watch that and enlighten ourselves. And then we'll have future sessions also. I would like the same participation by all of you. It was great learning for all of us. So I think everyone can give your suggestions, what can be improved and what can be done. If you have any suggestions, we are here to discuss now. Priya, are you there? Can you put the grid mode or whatever to click the
Yes,
photo?
sir. I'm just trying to get everyone on one frame.
Okay, so that is Dr. Priya.
Hi,
the
everyone.
Backbone of our webinar.
So yeah, everyone's on grid view, but there are only 10 participants with the videos on.
Okay, it's rest of you, please put your videos on. I think. Okay, are you getting everyone, like whoever is on, like?
Yes, sir. Yeah, I'm getting it. Okay, I'll just click it.
I think Rela team is still active. Full pumped up.
I'll just take the screenshot then.
Okay. Everyone ready? Like you tell when you're clicking.
Yeah, I'll just tell 3, 2, 1 and then you hear the sound. Okay. 3, 2, 1. Go.
Okay, done?
Yes, I'm done.
Okay, thank you. Thank you, everyone. So is there anything that you want to share? Irana sir, Enaridia? Unmute. Okay, I think.
Just a second. Sir.
You let everyone unmute, like let anyone unmute everyone. Like, whoever wants.
Yeah, I think you can do it.
Okay, Saurabh, you were there for the photo?
Yeah, I was there.
Okay. Thank you all. It was good. And many people
Thank you.
appreciate, and everyone's asking, like, send, have you recorded? Please, we need video. So it was good overall, and many participants were there.